a combination of vasoactives plus endoscopic therapy. So fresh hematemesis after 2 hours of drugs plus EVA, 2 grams or more drops, increase in heart rate or decrease in BP or unfortunate death. First three will require change in your strategy. In just 2 hours time, you have to make a decision, not 48 hours. What are the approaches? You have one, decompress means pressure in the portal system is reduced by tips or percutaneous transvenous embolization so that collaterals are embolized. Or you compress by giving a Denisella stent. What are the predictors? The patient has come from emergency and your colleague or your senior has called, भाई ये दोबारा bleed करेगा या नहीं? If you have a facility, do a pressure if it is above 20. If the patient has infections, if the patient is actively bleeding at endoscopy, you don't need an HVPG, you do a spurter, he has a chance of bleeding about 3 times again. So be ready if he has PVT or his child C. Now, this I'm showing you some data on. This is the data which Shakti, who had done the work, is to show you if the HVPG is above 21, the chance is 97%, and it is specific that this patient will have failure of combination. He had a study where several of these patients were monitored for 24 hours, and this was infusion of terlipressin continuous versus bolus. I'll show you the data. Now, if the MELD at presentation is above 23, let's say 24, you say to the relatives, look, this chance of rebleeding are very high. Now, this is continuous versus bolus terlipressin in ABB. HVPG responders at 12 hours. If you see in this, the response in 12 hours, the response in 12 hours you will see is much better in patients who have got a continuous infusion, and at 24 hours again it is there. And what is important is you require just 4 milligram dose compared to a 7 milligram dose in 24 hours for getting this. So less of the dose, better response. So therefore, you and the adverse effects are much lower. So Turley infusion for acute bleed is superior to Turley bolus. Unfortunately, it has not been submitted as yet. And this is the HVPG reduction at 12 hours, which is better with bolus and is maintained at 24 hours. As I showed you earlier, treatment related adverse effects are lower in the patients who have got continuous infusion than a bolus infusion. Now, how to predict a difficult bleeder? One is the chance he will bleed again. One is prediction. But now it's a difficult bleeder. Now, difficult bleeders are of three types: location, post EVL, and the choice of therapy will depend. Let me show you. Now, this is a hiatus and where there is a bleed. Now, here there is a guy who is bleeding. Let me see if I can play it. Now, the bleeds are in this patient very, very close to the GE junction. Now, if the bleeding is very close and then there is a clot over this, if you will put an injection into this patient may have a problem. And therefore, in such a patient, you will just need to put some hemo spray. And I'm not sure, there are no large studies, but this is what I generally suggest. Now, there is another patient here. And there is another patient here. I'm just showing you comparison of these two. Now, this is just, there is a small window where about 5 millimeter is available below. You can, in this patient, put a band. In the other patient, which is very, very close to the GE junction, you have a risk, and therefore a sclerotherapy is advisable. Band should not be done when your space is less than 5 millimeter. You will have gastric mucosa and there can be a problem in that particular patient. So three important locations in this. The next is a guy who has got, he came to us, CTP 11, MELD 23, has a risk of bleeding again. And he did have a post EVL ulcer bleed. In a routine EVL, he didn't come with a bleed. We created a bleed, and this bleed showed that there is an ulcer. This ulcer came after 12 days. One of our colleagues did a sclerotherapy, and in 4 hours, he again rebled. And now here is a massive bleeder in this patient. Now, such a patient, you can do a Denisella stent. You have to compress. You have done enough of injections in this. This is an old video. I hope it runs well. It's just to show you the active bleeding. And in these patients, you can put a Denisella very comfortably. This has a low, Sangstake and balloon type stuff. Most of our colleagues put it very well. And after you have positioned it well, the stent will stay for a while. The bleed has stopped, and then you can easily remove this stent after a few days' time. Don't keep this stent for more than 7 to 10 days. If you have a problem, the patient's stent has slipped, you can pull it back and it can be positioned very well. This is just to show you it can easily be taken out without any difficulty. So let us come back to our difficult bleeder or a persistent bleeder. We have done all endoscopic therapies. We are all expert endoscopists. We think we can, but still there are many patients who will not, and they might require an intervention radiologist tips because, as I showed you, if the pressure is about 21, 20 or 21, this guy will not respond. He will bleed. It's like a pressure cooker. Here is somebody who had a SANS taken and he required a tips. And all of you are aware of the NEJM paper of Garcia Pagan, which shows that if the patient has early uh, tips in these patients, early was 72 hours in them. There was only one who rebled compared to DREX plus band ligation. Secondly, survival was superior compared to drugs plus EBL. Therefore, the reduction in pressure is far superior. Our own experience, I am not showing you, I think the slide is missed. We have done close to 130 acute variceal bleeds, and these patients have done well, even with child's score of about 10 or 11 and MELD about 25 or so. Gastric variceal bleed, you are fully aware, it is GOV1 or it is a GOV2, and this is a large GOV2. This is a large GOV1. Large means anything which is more than the size of the endoscope. This is an IGV1, nothing around, and you have size is large, and you have a duodenal varix bleed. Sorry, it should move. Yeah. What are the predictors of first bleed and survival after GOV2 or IGV1? The size more than 20 millimeter. I told you large is above the scope, that is 10 millimeter. But which varix will bleed and rebleed if it is 20 millimeter? MELD is above 17 and there is portal hypertensive gastropathy. And in such patients, you will have probably, you can give glue very well and you can block these patients. Survival also depends on MELD above 17 or so. There are small number of tricks. I'm sure each one of you is an expert. This is meant for fellows if they are all anywhere around. Just to say that glue, distilled water, injectors, definitely two, acetone, and you should not be doing any suction. This is a GOV2 bleed. This is a GOV1. This is a GOV2 which has bled recently. This is a large gastric varix with red color spot. This is IGV1. This is just to give you a little idea of the tricks of gastric variceal. This is a large needle. Generally, I prefer about 6 millimeters of needle and 23 or 21. Now, because of the aqueous glue, we can use a 23 gauge, and this is a large varix, IGV1, maybe about 3 centimeters, and it has red color signs. What is important is just simply is to see that once you inject, you have a red catheter sign or so. These are the glue which is placed inside. You put the needle in. Before putting, you just touch just to make sure, and your angle is there. Be as close to the mucosa of the gastric mucosa rather than on the other side. Don't pick up the most prominent part. Pick up the part which is close to the this, so that you are coming close to where the blood is coming out. Once you are there, I'm sorry, this is too long. It should have been edited to make it smaller. I can run it. The only thing I want you to be aware is that once you are in it, you will see the what is called as a red catheter sign. This is to be sure that you have blood inside and you are in the right varix. You can see that very well. Okay, I'll just go to the next. Now, this is an important slide. This is to show you ischemic hepatitis. Why ischemic hepatitis is important? Patients with cirrhosis have high wedge pressure. They have a decreased hepatic venous blood flow. There is a congestion there. Also, their MAP is generally low. So, as it is, patients are compromised in the situation of varices. And a variceal bleed produces hypoperfusion, low oxygen delivery availability, cellular hypoxia, and finally, they can get a hepatocellular dysfunction. ALT can be high. If the bilirubin is more than 1.5 or if the LDH is high, do remember high bilirubin in 24 hours is not a good sign post bleed. This is our data on tips. Somehow the slides got mixed. This is to show you if the MELD is even more than 25. Some of these are patients who were on vasopressors. Survival would be about 20% or so. And this is tips versus Danicella. This is this year's presentation, oral presentation. SEMS versus tips. You can see that in patients who got tips, they are far superior as far as survival is concerned in them. This is the ischemic hepatitis. If the patient receives NAC, he survives. Those who develop ischemic hepatitis, more are dead than they are alive. I'm just going to, sorry, this is slight mix up. So this is my summary, HVPG and acute variceal bleed. HVPG helps in stratification and outcomes in acute variceal bleed. Your door to needle should be less than 30, door to scope less than 6 hours, junctional varix glue because you have no space to band, failure to control, wait 2 hours no more, sometimes even on the table, and change your strategy and emergent tips within 6, 8, 24 hours. Post EVL ulcers, if it is a decompensated, you might do a BRTO or you might do a Danicella, or less than 17, definitely tips can be done. With that, I thank you all for giving me the opportunity to be with you. Thank you.
Thank you, Professor Sareen, for finishing exactly your time. That's a wonderful, and yet you could cover every aspect of it, starting from the portal pressure, the difficult variceal bleed, the time to needle and the door to scope, and ischemic hepatitis and amelioration of ischemic hepatitis, and in difficult bleeding, the role of tips, as well as BRTO. That is a complete coverage of the subject. And we have 5 minutes to ask Professor Sareen any questions. I expect, Kausal, the questions should be in the chat box, no?
It's in the Q&A box, sir. If you just click on the Q&A box.
Q&A box, okay. Well, Professor Sareen, it is from Dr. Jayanti Venkataraman. In volume overload state, is bolus terlipressin preferred to infusion? That is our question. What she is meaning that whether in a patient who is overloaded volume, giving a continuous infusion with terlipressin, will it increase the volume or it will help to decrease the volume, or whether there will be
very good question. For simply understanding the importance, terlipressin increases afterload, while albumin increases preload. Now, if the patient already has a high preload, like patient is volume overloaded, giving terlipressin may have a problem. You are absolutely right, but still infusion will be safer than giving a bolus. So, but you should be cautious that you do not increase the afterload too much in these patients. So always the rule is half transfuse. Suppose a patient has lost a liter, give 500 ml, whether it is blood, whether it is plasma, whether it is saline, anything, half transfuse.
To corollary to it, Professor Sareen, do you want to measure before giving terlipressin the IVC diameter in each patient?
Not really. I don't think so. There
Because
is no
CT is
need.
not a
Yes,
good indicator,
it's a
right?
good indicator, but if you have the facility and if you would like to, but normally I would look at the neck veins and I will be quite okay
Simply, okay.
with the neck veins.
So the clinical determinants are much more important to take at the clinical decision, whether to give an infusion or whether to give a bolus. Fine. Any other questions from the panelist or the moderator?
Dr.
Sir,
Karan,
can I ask you? Sir, can I ask you a question?
Yeah.
So what is the rate of terlipressin infusion you prefer to give, sir?
Yeah, infusion you can give the same dose what you have 4 or 6 milligram can be given continuously. You can
Over 24
titrate it
hours.
so that it is for 24 hours. 4 milligram is our standard. If you find it is not working well, you can increase it to 6. But don't believe me for everything. It is not published. It is only presented. But we use it routinely now, terlipressin, as an infusion.
Dr. Sareen, this is
Second thing,
Dr. Sharath here. If I can ask you a question, with child C patients who have large varices, high risk varices, who are listed for a transplant, I've had 2 occasions in the last year where I did a prophylactic banding and they ended up with an ulcer bleed and they died. So I'm now very nervous banding these child C patients, especially if they're on a wait list for a transplant.
You have a very important point. So, in fact, I was the strongest proponent of varicella primary prophylaxis and bleed. But in child C, anybody who has got a MELD above 26, I would give beta blockers. I will certainly wait for 4 weeks to 6 weeks before I even touch with a band because beta blockers will at least decrease the pressure. So, at the first instance, I would not recommend doing a band ligation in these patients. Beta blocker doing HVPG is very easy, very safe, decrease the pressure. If you can't do an HVPG, just get a target heart rate. Use carvedilol, get the target heart rate down, it's okay. But don't do banding.
What if they're already have a low MAP because of advanced cirrhosis?
Yeah, that's a very good, and therefore the trials are on midodraine plus beta blocker. So a high risk varicella bleed transplant candidate, he would be benefited by midodraine plus Ciplar, propranolol, not carvedilol.
Thank you.
May I
Thank you,
ask a
Professor
question?
Sareen. I think
Yeah,
we have
May I ask a question?
time by 3 minutes, and I will request my co-chairperson. You can always ask Dr. Singh question to Dr. Sareen. Yes, you can ask.
I sent it on chat.
Oh, he has asked. Have you
He has asked Dr. Virendra Singh has
during
asked a
COVID
question.
time? But that's a general questions on endoscopy and endoscopic interventions. You can discuss Dr. Singh with Professor
Okay.
Sareen. This
No
COVID
problem.
practice, there are guidelines. You know it very well. During emergency as well as in the elective endoscopies.
Okay.
And I will request Dr. Dadij, who is my co-chairpersons, to invite the next speaker and introduce him.
okay, sir. It's my pleasure to invite Dr. Sarath Putta. He is a senior consultant and head of Department of Hepatology and Liver Transplantation at KIMS Hospital, Secunderabad. And he'll be speaking on approach to an SOL detected in a cirrhotic liver. Cirrhotic liver, SOL liver. Dr. Sanjay, please.
Yeah. Thank you, INASL. Thank you, Kaushal, for asking me to talk about approach to a focal lesion in a cirrhotic patient. I'll briefly touch upon risk assessment for HCC in a given cirrhotic, imaging modalities once you find a focal lesion, and increasing role of LIRADs.
Dr. Putta,
Can you make it full screen?
can you
Please?
make the full screen? You go to the left-hand side of the camera.
Use slideshow.
Use slideshow. Second, yes, this one. Yeah, thank you.
Yes, thank you.
The need for repeat imaging or biopsy in indeterminate lesions, treatment strategies, and a couple of clinical vignettes, more of a question than an answer. So when you find a focal lesion in a cirrhotic, you hope for the best, but you prepare for the worst. You assume that it is hepatocellular carcinoma until proven otherwise. Now, you would hope that these lesions are detected through scheduled surveillance rather than incidentally or accidentally. Every cirrhotic should go through surveillance. And in the absence of preventive strategies, the best chance we have to control HCC is through surveillance. And if you diagnose them early, you have the option of applying curative modalities, where if they're diagnosed late, you're left with palliative treatments and a median survival of not more than 1 or 2 years. It's useful to remind ourselves that patients with viral hepatitis and cirrhosis carry the highest risk. It's a staggering 3 to 8% risk of liver cancer per annum. So if you're following hepatitis B cirrhotic for 5 years, they stand a 20 to 40% chance of developing cancer during this period. Now, the quick word about whether you use ultrasound or ultrasound and alpha-fetoprotein. Alpha-fetoprotein has been in and out of various society guidelines. In clinical practice, I use both. And the latest ASLD guidelines have reinstituted AFP into their recommendation. You can do it with or without AFP. Now, once you've identified your lesion, you then progress to doing a multi-phase CT or an MRI. Now, between CT scan and an MRI scan, each one has its advantages and disadvantages. Choosing between one or two is like between 6 and half a dozen. CT is widely available, expertise is more readily available, but then you have radiation exposure and limited renal dysfunction. MRI is being used more and more. In our experience, we find that it is more sensitive. It's sensitive for smaller lesion, which is in keeping with published data. Contrast enhanced ultrasonography, it's not something we do at our center. I think in some expert centers, it has very high sensitivity and specificity. And it is useful in a subgroup of patients who have renal dysfunction, who have CKD, where you're neither able to do a contrast enhanced MR or a contrast CT. Now, Kaushal asked me to focus a little bit on LIRADs. The imaging, I'll talk about the imaging characteristics of the lesion once you've evaluated with a MR or a CT. Now, as you all know, LIRADs is liver imaging, reporting, and data systems. We've been using LIRADs in our center for the last few years. It standardizes terminology. It classifies a liver lesion and places it into a category, which makes it easy to predict risk for that particular patient. The first version was in 2011. Since then, we have multiple versions. You now have 2018 version, and this has been revised with accrued experience and emerging evidence. The previous version of LIRADs has been put to clinical testing, and it has been shown to be effective in clinical practice. So once we identify the lesion, we perform a triple or a quadruple phase CT or an MR on the patient. So for the benefit of the postgraduates on the course, so the quadruple phase or a triple phase refers to, typically a triple phase refers to an arterial phase, a portal phase, and a late phase. Arterial phase is typically 30 seconds after you've injected the contrast, and the portal venous phase is a minute after you've injected contrast, and the late phase is typically around 5 minutes after injection of contrast. So how do you identify that? I'll go a little bit deeper into radiology, because we are not only hepatologists, we do have to look at our scans ourselves. We have to be a bit visual with our patients, particularly our cirrhotics. So arterial phase, you see a lot of contrast in your aorta. In the venous phase, the contrast weakens a little bit, and you start seeing it in the portal vein. That is the portal venous phase. And in the late phase, typically you see a little bit of contrast in the IVC, or you may not see anything. Now, LIRADs describes 5 major characteristic features, and these have been designed to identify hepatocellular carcinoma. So the first and foremost is contrast enhancement, which is a significant feature of HCC, typically in the late arterial phase, which is about 40 seconds after you've injected contrast. And then like they enhance rapidly, they also wash out in the portal phase. What you can see here in this image is that the central part of the tumor has blacked out compared to the rest of the liver. And that is the arterial phase for comparison, where the tumor is hyper enhancing and here it is washing out. And then if you can see a capsule which is the white rim you're seeing in the bottom photo, that also constitutes a major feature on LIRADS. And bigger lesions carry a greater risk of harboring HCC. And threshold growth is probably the most important feature of everything that I've described now. So you have 5 features. So if you have a large lesion, which is growing in size, which is enhancing in the arterial phase, it is washing out in the portal phase, and you have a capsule. Those are the 5 signs which you rarely get in clinical practice. More often than not, you're dealing with between 1 to 3 features. Now, coming to how LIRADS classifies these lesions. So LIRADS 1 is definitely benign. For example, you have a liver cyst, which is identified on ultrasound. They don't enhance and they don't wash out. So it's fairly straightforward. It's LIRADS 1. LIRADS 2 is also benign in vast majority of the patients. The difference between LIRADS 1 and 2 being, if you find a specific solitary regenerative nodule, you would want to call it LIRADS 2 because you cast an element of doubt about the definitiveness there. LIRADS 4 and 5 and LIRADS M constitute malignant lesions. Now, LIRADS 5 is where you have a big lesion which is enhancing and it is washing out. So you have 3 major features that constitutes LIRADS 5. If you have 2 of the 5 features I described earlier, that constitutes LIRADS 4. So LIRADS 5 is definite HCC. So you don't need a biopsy, just the imaging features are enough for you to go ahead and plan your therapy. It can be a resection, it can be transplantation. In fact, you're discouraged from biopsying these lesions for the risk of seeding. LIRADS 4 is where you have 2 features, but still the level of certainty is quite high. You can still go ahead and treat these patients as HCC. LIRADS M stands for malignant lesions, which enhance a little bit, which wash out a little bit, but it's not very characteristic of hepatocellular carcinoma. These are called targetoid lesions. So they enhance at the rim and they wash out at the rim. So this is typical of cholangiocarcinoma, for example, intrahepatic cholangiocarcinoma. Now the true bugger in all this is the indeterminate lesion, which is LR3. LR3 is a smallish lesion which can enhance, but it doesn't wash out. If you speak to radiologists, the one feature that they say are the 2 features that describe a malignant lesion is a washout and a growth in size. So LIRADS LR3 lesions typically do not wash out. They can enhance, but they are small and they don't wash out. Now, so they generally have one major feature. So what does it all mean? So now you have your patient, you've found a lesion on surveillance, you've done your triple phase studies, and you've now put them into certain brackets ranging from LR1 to LRM. So LR1 and 2 are benign for all practical purposes. LR4, 5, and M are malignant. LR3 is the indeterminate category. So if you LR1, 2, and 5, you don't need to do anything further. You have your diagnosis. LR3, LR4, and LRM, you know that it is malignant. There's a 75 to 80% chance that this lesion is malignant. More often than not, LR4 is HCC. In clinical practice, we find that most of the HCCs that present to us are LR4 rather than an LR5. So most of these patients, if they have a high alpha fetoprotein, you do not need to embark on a biopsy. If you want to go ahead for a resection or for a transplantation, you don't need to biopsy these patients if your alpha fetoprotein is high. There are instances where you might need to. Now, what do you do with an LR3 lesion? Like I said, these are smallish lesions between 10 and 20 centimeters. They enhance, but they don't wash out. You keep these patients under strict surveillance. You do imaging on a more frequent basis. There is a 30 to 40% chance that this patient might harbor a HCC, which will come to light at a later stage. Now, AASLD has incorporated LIRADS into its practice guideline. INASL is slightly different. INASL recommends that anything more than 1 centimeter, unless the radiology is consistent with HCC, you should have a very low threshold to biopsy these lesions. Now, you do your surveillance and you characterize your lesion ultimately to give your patient a chance to have a curative shot at treatment. So you should ideally catch them in early or very early stage, in which case you can ablate, resect, transplant. This is outside the scope of my talk, but your surveillance is designed to catch them at a very early or an early stage. Now, that is the theory part. I'll just present a couple of case vignettes that I was faced with in the during my practice recently. 45-year-old female. This is a classic HCC. Hepatitis C diagnosed in 2013. It was eradicated in 2016. A 10 mm space occupying lesion was identified in November 2019 in her local practice. I'm not sure if the patient was lost to follow up or it was not impressed on her that she needs a repeat scan. She came to me in August, and what I found was a 4.5 centimeter enhancing mass in the caudate lobe. Alpha fetoprotein was not raised, and we did a LDLT for this patient last week. Now, what this highlights is that theory and the recommendations to one side, there are problems with the patient's understanding. We need to communicate surveillance better to the patients, and we need to strictly follow surveillance and the LIRAD's recommendations. Now, this was one of the more challenging patients I managed recently. 50-year-old man with hepatitis B cirrhosis diagnosed in 2016. His DNA was undetectable in 2019 when he first presented to me, and he was identified to have a focal lesion on ultrasound. His alpha fetoprotein was 9. We did a triple phase CT which showed a 4.7 centimeter lesion. And this was reported as a LIRADS 3 lesion because it did not enhance, it did not wash out. So this is the images of the CT. This is April 2019. But because of the size of the lesion, I was concerned and I got a biopsy. Now the biopsy showed a lot of a steatotic nodule. And what you have on the top right is CD34 staining, which showed some vascularity. Our pathologists were not sure if this is a regenerating nodule or a HCC. Then we did the glypican 3 immunohistochemistry, and it was not glypican rich. So we passed it off as not a HCC. And 3 months later, I repeated a scan, and the scan showed that there was some growth, but it was sub-threshold. It did not grow beyond the 50%. So I did not take the patient back to MDT. Instead, I spoke to my radiologist on phone. I ordered another scan in 3 months' time. In 3 months' time, when the patient came back, we now had a LIRADS 5 a tumor which had grown to 6 centimeters. So it was just crossing the boundaries for extended criteria for transplantation. So patient underwent a TACE, and luckily we had an excellent response to TACE. What you see here is post-TACE, that's lipoidal there, and there is very little enhancement in the tumor. And the patient was, we listed him for a transplant, and he was lucky enough to get a transplant in 3 to 4 months, during which time his lesion did not grow and the explant did not show any viable tumor tissue. So the lessons learned for me here was that AFP sensitivity is low. And when you have a lesion that's more than 20 millimeters, you have to be extra careful. Biopsy is not foolproof. There could be a sampling error. Maybe I should have gone back at 3 months when he came back to follow up. I should have gone back to the MDT, repeated the biopsy, which I didn't. Things went our way with this patient, but some patients can just cross the threshold and develop unresectable disease. And MDT practice is essential when you're managing these patients. My final case vignette is a 38-year-old man with hepatitis B cirrhosis who was on entecavir for a year. His hepatitis B was undetectable, and we detected a space-occupying lesion on his ultrasound. We went on to do a CT, which did not, this is the arterial phase, which showed some enhancement in segment 4, but there was no washout. It was poorly defined, and it has been reported as a LIRADS 3 lesion as of now. And what you see on the right-hand side is that his alpha fetoprotein, which was in fact actually 54 to start with, dropped down to 18. And we did a hepatitis D delta viral RNA and IgM on this patient, which has come out positive. This guy is still under follow-up. That is still an indeterminate lesion. And this is a real-life scenario which we are faced with. So to summarize, close surveillance is the cornerstone for identification of lesions and for offering curative therapies. Ultrasound with or without AFP to be used for surveillance. At our center, I use ultrasound and AFP for most of the patients. It is a truth that not every ultrasound that the patient has is at the hands of liver interested radiologist in most centers, except for a few centers like ILBS and some of the major institutions in India. Triphasic CT or MRI are modalities of choice for evaluation. LIRAD's categorization can be really useful to standardize reporting and guide management. AFP is useful in aiding diagnosis, and a multidisciplinary approach is very important. Thank you, INASL, for giving me this opportunity. That's the end of my talk.
Thank you. Yeah. Thank you, Dr. Sarath, for a elaborative talk on liver lesions. So this is open now for question and answers. Can I ask you one thing?
Yeah.
Suppose a cirrhotic liver with child C status, and then has come to you with SOL liver, and it is a confusion between regenerating nodule and a malignancy.
Okay.
So what is your advice? How do you go about it?
Sorry, I think your voice broke in between. Can you repeat that question? I'm sorry about that.
A child C status,
Yeah.
SOL liver around 3 centimeter, and LIRAD 3. Then what will you do? Like, I have a confusion between a regenerating nodule and a malignancy. What will you do?
Well, if you go by the guidelines from AASLD, if you categorized it as LIRADS 3, there are choices. It does not tell you that you have to do one particular thing. You can do your alpha fetoprotein first. I'm assuming that the alpha fetoprotein is not raised. If the alpha fetoprotein is beyond 400, you have your diagnosis. But if your alpha fetoprotein is not raised, you can choose to follow up imaging in 3 months' time, or you can choose to biopsy the lesion. But as you said, child C, sometimes these patients have ascites, they have coagulopathy. So the biopsy is sometimes easier said than done.
Biopsy not possible.
So I mean, you could choose to do another modality. If you've done a CT, for example, because lesion is on the bigger side, you could maybe do a triple phase MR and see if it comes out with, if there are certain ancillary features. Now, what LIRADS talks about most of the time is major features like enhancement and washout, but other features like the case I just mentioned, the lesion had a lot of fat in it. So if you have some of these ancillary, and there was some diffusion restriction on MR, so MR can give you that slight additional information which can tip you towards a biopsy or an earlier scan, for example.
You take him for directly transplantation if he's falling into that category.
I think taking somebody with LIRADS 3 directly up for transplant, if their MELD is low, I mean, presumably the patient is child C, so he meets the transplant criteria anyway. But if the patient is child A and you have this LIRADS 3 lesion, then I don't think there is enough there for me to waitlist that patient for a transplantation.
If it is a child's A, doctor you can do a biopsy, you can do a MR scan.
Yes.
And I think there have been studies to add PIPCA 2, and which adds to the diagnosis. So even though it is a LR3, you can use other modality to clarify your doubt. And Japanese, actually, what they will do, or Koreans, if they have LR3 and the child's A, and if it is a resectable tumor, they will resect it. All Southeast Asia will resect it. And obviously, the resection depends upon the MELD score and presence of portal hypertension. If the MELD is less than 9 and there is no portal hypertension, HBPG is about less than 8, the chances of decompensation will be less than 15%. So these are multiple studies available, Dr. Dadij, from Southeast Asia, where they see much more of cancer. But if it is child C and you have an indeterminate nodule, transplant is the best option, because of the other person is going to die of a liver failure or its complications of liver failure.
So rather than going behind the nodule, you can go for transplantation.
Is there any question, Dr. Dadish?
I think I didn't see anything in Q&A box, so I think we can close up.
Then Dr. Pankaj, our course director, we can both, Dr. Dadij and me, hand over the podium to you. And thank you for giving us this opportunity to listen to this brilliant talk and to moderate this talk. And thank you, Dr. Dadij, for actually sharing this session with me. I'm grateful.
Thank you, Professor Acharya.
Yes, sir.
Thank you, Professor Acharya, Dr. Nandi, and Dr. Dadij. We now go on to the second session, and this will be chaired by Professor Y.K. Chawla, Professor Anup Saraya, and Dr. Manisha Bangar. Dr. Chawla was at PGI Chandigarh and is currently the Chairman Academics of Kalinga Institute of Medical Sciences, KIT University in Bhubaneswar. Dr. Anup Saraya is Professor and Head Department of Gastroenterology and Human Nutrition at All India Institute of Medical Sciences in New Delhi. And Dr. Manisha is a Senior Consultant Gastroenterologist and Transplant Hepatologist at Virinchi Hospitals in Hyderabad. We welcome all three of them, and we are grateful to them for having accepted our invitation. Over to you, chairpersons.
Thank you, Professor Rakesh Agarwal, for asking us to chair this session, a very important one. To talk to us on management of cirrhosis with ascites, we have Professor Rakhi, who's very well known to all of us. She's an international figure, and she's a star at the Institute of Liver and Biliary Sciences. She's Professor of Hepatology, and she would talk to us on the management of cirrhosis with ascites. Rakhi, please.
Thanks, Professor Chawla, for that very kind introduction. And I would also like to thank Dr. Kaushal and INASL for giving me an opportunity to talk on management of ascites and cirrhosis in this INASL PG course. So I hope my slides are visible.
Not yet,
No, ma'am.
Not as yet.
If you take your cursor down, you would see
Yeah,
a
so it
green
is
color.
coming now. It's not coming.
No problem. Take your time. Don't be flustered. No problem. Technology is technology.
Okay. I
There
think
you are.
now it should be visible.
Yeah, there it is. Thank you.
Yes, we can see.
Okay. So
And just put it in a slideshow. Yeah.
So I would first start with a real life case scenario and then discuss the management. And this I will divide into uncomplicated and complicated ascites, and will discuss some contentious issues like the use of beta blockers in these patients. So this is the case scenario to start with. This gentleman who was a 59 years old male, and he had a corrected BMI of 24. And he came to us, this was not the corrected BMI, the BMI was 24, and this patient had been diagnosed with portal hypertension, had grade 3 esophageal varices, and had hepatitis B related chronic liver disease, and his first decompensating events had happened 11 years back with jaundice and ascites, and he had been stable on antivirals and a low dose of diuretics. When he started to have an increase in his worsening of the liver functions, he was adherent to his antivirals, so he had some worsening of his jaundice, and his problems was the development of refractory ascites with the requirement of large volume paracentesis in the last 3 months, which he was requiring every 3 to 4 times. And he also had a history of HE, which looked like secondary to paracentesis induced circulatory dysfunction. On examination, this patient had a low BP of 90 by 54, a MAP of 70. He had decreased air entry on the right side. He was having tense ascites, and he was frail with a frailty score of 5.23. His initial investigations showed features of hypersplenism. This patient also had normal renal functions with mild elevation of urea, The creatinine was normal, and this was supposed to be his baseline serum creatinine. He had mild hyponatremia, his eGFR was normal, he had mild jaundice, and he had low serum albumin. His CT scan did not show any HCC or PVT, which was ruled out, and SBP was also ruled out. The endoscopy, as we already mentioned, showed grade 3 esophageal varices, and his pleural and ascitic fluid analysis did not show any evidence of infection. He had presented to us with severe respiratory distress, because of which he was admitted. And he had a large right-sided hydrothorax. So the pathogenetic basis, we will go back to the talk first, and then we'll come back to the case. So we know that in the natural history of chronic liver disease, ascites happens as an ominous complication. It develops in almost 50% of these patients, and it has an expectancy of only 2 years in the absence of any treatment. And with refractory ascites, which is a more severe form of ascites, this happens with long-standing liver disease and in patients where the ascites gets uncontrolled, as was seen in our patients. So these patients have impaired renal sodium excretion, they have hyperaldosteronism, and with time, these patients also have a decrease in eGFR, they have a decrease in the renal plasma flow, which together results in the development of renal dysfunction, predisposes them to development of HRS and AKI, and the development of AKI also, with the use of diuretics and also any other complications that are associated with this. Now, the systemic hemodynamics in patients with cirrhosis and ascites also, we are well versed that these patients are effectively hypovolemic, and this is an important point. So they are not in fluid overload. Most of the times these patients have effective hypovolemia, they have a hyperdynamic circulatory state, they have splanchnic arterial vasodilatation, like we saw the diastolic blood pressure in our patient was just 54, a decreased systemic vascular resistance, which together results in the impairment of renal function and the development of refractory ascites. And in patients with refractory ascites, the GFR is further reduced, even though this GFR, which was calculated using the, again, that is a different talk altogether, we cannot go into that. So even the estimation of GFR in such patients is a big challenge. How do we estimate the real functions of the kidneys? Now, there's a new theory of development of complications in patients with cirrhosis, wherein they suggest that apart from already known hemodynamic alterations, there is a definite bacterial translocation, the damage because of the pathogen-associated molecular patterns, and the release of the pro-inflammatory molecules. There is a systemic continuous endotoxemia, which together also contributes to the circulatory dysfunction. So they have low-grade systemic inflammation, and they also have gut dysbiosis, which together results in the development of all these complications. So before we start assessing the patients with cirrhosis, it's important that we classify the type and the severity of ascites. So uncomplicated ascites is which is not infected, not associated with any other complications. However, the challenging group is the refractory ascites, which cannot be mobilized, or the early recurrence of which cannot be prevented without a therapeutic paracentesis. And there are set guidelines. And what we commonly see in our clinical practice is the diuretic intolerant ascites, where the patient gets refractory to therapy due to the development of diuretic-induced complications. And most of the times, we are not able to increase the dose of diuretics, and what is recommended is that by the INASL guidelines that we can go up to spironolactone of 400 mg and furosemide 160 mg in these patients to have a control of ascites, which is not possible in most of the Asian patients and Indian patients that we deal with. So how do we manage these patients? So the first basic step in the management of these patients is identify the etiology, because etiology will definitely improve the overall outcomes of liver disease. So if the patient would be having alcohol, it is important for us to ensure a good nutrition and abstinence. In fatty liver patients, it's also important to assess for other organ involvement, which can contribute to the development of ascites, assess for sarcopenia in these obese patients, and see how you target a weight reduction without having them to reduce their muscle mass. Hepatitis B and C, we need to check the efficacy, adherence to the antivirals, and see the appropriateness of the therapy. In autoimmune, yes, in some particular cases, we can go with steroids in context of active cirrhosis and ACLF after proper management and under good careful monitoring. HVOTO, we just need to put these patients on a separate set. The ascites has a different way to be managed in this set of patients, and Wilson's, we need to put them on chelating agents. Now, salt restriction is the backbone of these patients, and it is also important for us to ensure that these patients are compliant with the salt intake. And that's the core of the management of these patients. And most of the times we see that these patients are taking surreptitious salt intake through use of different forms of food items. And that has to be dug out with a careful history. And if you're not able to do that, we can do a spot urine sodium to potassium and a 24-hour urine sodium to identify whether these patients are compliant with the salt intake or not. And there is no role of water restriction. This is an important point, and water restriction should be taken and should be done only if patient is refractory to all other forms of therapy, or the patient has CKD associated ascites, or the patient has dilutional hyponatremia. Now, diuretic therapy forms the first step in the management. After we have done the salt restriction, we have to put these patients on diuretics, and we have two basic classes of diuretics that are available. We have the loop diuretics, which act at the ascending limb of the loop of Henle, and they act on the sodium potassium 2 chloride co-transporter, and they increase the free sodium excretion. So we learned that there is a defective urine sodium excretion. The loop diuretics will improve this. And there's the aldosterone antagonists are also another important. So they cause improvement in the natriuresis in these patients. Now, how do we start dosing, and how should we be choosing the right diuretic in our patient? So obviously, if the patient has mild ascites, and the patient is not having pedal edema, not too much of anasarca, it is always better to put these patients on spironolactone as an initial therapy. And we can add or simultaneously initiate loop diuretics in patients where the response is either inadequate, or the patient has a more severe form of grade 2 or 3 ascites and has associated pedal edema. And we'll see some studies supporting this concept of how do we be giving these diuretics. And spironolactone causes only a modest diuresis, and the usual starting dose, we should start with 50 mg. We should not be increasing this dose very frequently because it takes time, and it is important that we increase the dose only not before 3 to 4 days and see, because the peak effect usually takes 7 days, and we can go up to 400 mg per day for spironolactone. Now, loop diuretics, we have furosemide and we also have torsemide, but furosemide is a better loop diuretic, which is much safer if the patient has in the mild to moderate cases of ascites, it is better. And it gives a very quick response. That's why when we use this loop diuretics, we get a response which is usually seen as quick as after 24 hours and as early as 6 hours if we give an IV preparation of furosemide. Now, this was a randomized controlled trial where they compared that whether spironolactone alone or in combination with furosemide could be given in patients who were non-azotemic cirrhotics with moderate ascites. And the results of this trial had shown that spironolactone is a better therapy, and there was not much difference if you use a combination of spironolactone as compared to using it alone. Now, what are the advantages of loop diuretics? Here they propose that because it will provide, as we already said, that it is will give us an earlier onset of diuresis in these patients, reduce the incidence of hyperkalemia because these are potassium sparing drugs, the aldosterone antagonist, and therefore hyperkalemia can be prevented. And thirdly, it may increase the efficacy by increasing the delivery of the sodium to the distal tubule. So these are the advantages of giving loop diuretics. Now, what about torsemide versus furosemide? So many of us are writing torsemide and some have we write furosemide, but what does the data suggest? So this was a randomized controlled trial, again, where they showed that if you look at the difference between the two drugs as early as 6 hours, the results were not different, and furosemide was as effective as torsemide. However, the effects of torsemide were significantly better with respect to improvement in the urine sodium excretion and the improvement in the natriuresis and urine volume at 24 hours. And further, if at all your patient with cirrhosis is having GI problems, GI absorption, because furosemide has a on 50% oral absorption. So if those symptoms are there, especially in patients with refractory ascites, it is better to go with torsemide, because in such patients, if you're giving furosemide, only 50% efficacy is obtained. Now, what are the effects of diuretics on hemodynamics and hormonal patterns? So are diuretics safe in our patients? So if you see the study, and this was a nice study where they showed that if you give torsemide and furosemide, and they did a 0 hour and 24 hours evaluation in these patients, and they showed that there was a decrease in the mean arterial pressure if you're giving torsemide, and similarly, there was an increase in heart rate and rather increase in the plasma renin activity and aldosterone. So the diuretics are actually doing some harm to these patients with respect to their hemodynamic parameters and hormonal patterns. And therefore, it becomes very, very important that we should not be rushing on to increasing these dosages. We should be doing an escalation and de-escalation with close monitoring for side effects. So how do we monitor these patients? While you're stepping up the therapy, it is better to call them once a week in your outpatient and see that you're achieving a target body weight reduction. And you can accordingly increase the dose of or add the loop diuretic if the patient was on only spironolactone. And it is better to check weekly kidney function tests before increasing these doses. And at each visit, you should be checking for signs and symptoms of volume depletion, symptoms of leg cramps, of symptoms of low blood pressure, because these are all the side effects of diuretics. And it's also very important that, because we learned that the most of the AKI also, as we know, that majority of them are due to diuretic related. So it's also important that we quickly assess and de-escalate these patients if they are not using, especially if these patients are having resolution. It is also important that you keep stepping down on the treatment as well. Now, this is a large study which was just published and it became very popular on using long-term albumin, routine daily dosages of albumin in patients with uncomplicated ascites. And this was a large multicentric Italian trial where they gave large dosages of 80 grams of albumin to all these patients of uncomplicated ascites for 2 weeks, followed by 40 grams for 18 months. And they showed that there was an improvement in all the liver-related complications, and there was also a survival benefit that was observed, which was independent of patients undergoing TIPS or liver transplant. So albumin was providing a survival benefit in these patients. And based on that, there was another trial which was published, the Preciosa trial, where they actually showed that giving even higher dosages than this dose, that is 1.5 grams per kg, which is almost equivalent to around 5 bottles of albumin a week, as compared to 1 gram per kg every 2 weeks. They showed that albumin will improved the systemic inflammation, it improved the plasma renin activity, and obviously the serum albumin concentration. However, this was a very small subset of patients, and we have to be validating these results before we propose such high dosages of albumin to our patients. And very recently, there was another subgroup analysis and a sub-study from the ANSWER study, which was published in Journal of Hepatology, where they showed that on treatment, serum albumin was actually predicting the outcomes of these patients. And what they suggested was that when they analyzed the same patients who were given albumin in the ANSWER study, they found that there was a close association between the baseline serum albumin and the mortality. So lower the serum albumin, higher was the mortality. Then when you start these patients on albumin therapy, then if the patients have an improvement of serum albumin and it reaches 4 grams per DL, then these patients have the best outcome. However, in patients who were not able to normalize the serum albumin, even though they were shown to have benefit with IV albumin therapy. So this is what they showed, that it is not necessary that you give very high dose. You may escalate and de-escalate, and giving albumin therapy in these patients, even if they do not normalize, is helpful. So we go to the difficult case of complicated ascites or refractory ascites. Here again, the checklist remains the same. We should be seeing that we are not missing on to the other causes of refractory ascites, like a portal venous thrombosis, hepatic venous thrombosis, other causes of mixed ascites, because 5 to 10% of cirrhotic patients, and when we see patients with refractory ascites coming to a tertiary care center, almost 25 to 50% of patients usually have mixed forms of ascites or other causes of ascites which would have been mislabeled as refractory ascites. So this is the core issue before we make this diagnosis. Once we've done, we have to check the salt compliance. And again, in refractory ascites, it is very important that we should do a urine spot sodium and see that if the urine spot sodium is more than 100, this implies that the patient is non-compliant with dietary sodium. However, if the patient is having a low urine sodium of less than 20, this implicates diuretic resistance. And here we should not be trying to give these patients diuretics, and this should be stopped because this will lead to AKI. Now, as compared to uncomplicated ascites, for patients with refractory ascites, liver transplant remains the only definitive treatment option, and it should be considered early on because these patients will quickly get into all the complications of large volume paracentesis, sarcopenia, frailty, infections. So a timely liver transplant is something which is the of utmost need soon after the onset of refractory ascites. Now, TIPS is also a very important modality, and TIPS can be considered, and we know that TIPS has shown survival benefit, and this was a large meta-analysis where they showed that patients who had TIPS, they had an improvement in urine sodium excretion, they had improvement in renal function tests, they had improvement in plasma renin activity, aldosterone concentration, and they also had an improvement in the systemic hemodynamics. The hyperdynamic circulatory state was improved, and also the coexistent, there was improvement in the energy intake, the quality of life parameters, the muscle mass. All these things were improved after TIPS. And there was a survival benefit, which was demonstrated by 3 randomized controlled trials when TIPS was compared head-to-head against large volume paracentesis. However, the TIPS does not confer survival benefit to all patients of refractory ascites. And if you see a subgroup analysis and we stratify these patients based on their MEL score, the higher the MEL, the poorer is the survival. So TIPS should not be offered to patients with MEL scores above 19 because here, these patients may also go up into more complications rather than getting benefited with TIPS. And it has the best outcomes if the patients have a low MEL score and refractory ascites. So early TIPS is better in these patients rather than doing it late in the course of refractory ascites, because TIPS-related liver failure is a detrimental complication, and this becomes a problem while managing these patients, and this has no treatment excepting an emergency liver transplant. Now, post-TIPS encephalopathy is also one complication that is noted after TIPS. And in this meta-analysis, which was done again on individual patient data, they showed that the frequency of HE was higher after 1 year of TIPS placement. So again, TIPS-related HE is a simpler complication, but it is more often seen at a longer period after the TIPS is done. And these are the risk factors. Again, the MEL score and the severity of liver disease, a patient who's already had an HE episode prior to TIPS, and placing large diameter stents. So now what is recommended is that if a patient, you're dealing with a patient who has a high MEL score, it is better to put a 8 mm or a 6 mm French stent, which could be better, and try to see whether you're able to achieve the resolution of ascites. Now,
Rakhi, kindly come to the summary slide. We've already reached the discussion time.
Okay, sir, sorry.
Yeah.
So just very quickly about large volume paracentesis. So we know that albumin is required for large volume paracentesis. We can also try vasoconstrictors, and even a combination of vasoconstrictors and albumin could be benefited. To reduce the incidence of large volume paracentesis, it is better to do a modest volume paracentesis. And midodrine is an effective treatment for refractory ascites. And there's a negative trial also on midodrine and albumin combination. Vaptans, yes, we can use in a select group of patients, but should be avoided in advanced patients with liver disease. And this was a recent meta-analysis on Vaptan therapy. The effects are very short lasting, and very low doses of Vaptans should be used. Alpha pump, again, not very popular because of the cost. Beta blockers, I would just say that there is still a mystery whether we should be using beta blockers, but yes, we should avoid them in patients who have low MAP, AKI, serum sodium of less than 130, or infections, and in patients with refractory ascites. Nutrition and frailty become the backbone, and we should ensure that these patients get a good calorie and protein. So coming back to a patient, this patient required admission. He required a large tapping from the pleural fluid. Subsequently, this patient was put on a good calorie and protein. He required midodrine. He was put on a low dose of diuretic and albumin at 60 grams per week. Beta blockers were withheld and Norflox was given. And this is a subsequent course. So this patient had resolution at 1 month and he had ascites grade 2. And by 6 months, his X-ray also showed improvement and the ascites has resolved. And what we did with the, we did a de-escalation, and by 3rd month, the albumin was reduced, midodrine dose was reduced, and diuretics were made also reduced, and his ascites had resolved. And these are the parameters, and we can see that after albumin, there was, after giving albumin, the patient has an improvement in serum albumin, and therefore he was a responder. He still remained in the pre-frail category, but he had improvement in all other parameters. And currently he's on 20 grams of albumin every 15 days. He's on midodrine 20 mg and lacilactone every 3rd day. Now, ascites, just to summarize, is a common and serious complication, and it has to be dealt with in a timely manner with liver transplant, especially in refractory ascites. Beta blockers should be avoided as far as possible, and nutritional and frailty assessment become an integral part of management. Thank you.
Thank you, Rakhi, for an excellent overview of ascites. We can have questions from the audience, from the moderators, but I have a couple of questions to start with. You said that salt restriction is important in these patients, and we know that the compliance is extremely poor in these patients. So what is the current recommendation? Is it 2 grams, or they've been a little more liberal going up to 7 to 8 grams now? And second is, I'm very happy that you've scored toracamide over furosemide. In spite of that, we see a lot of people using furosemide. I personally feel toracamide is definitely better than furosemide. And lastly, is 6 to 8 grams of albumin the right amount to be given, or there are some trials where they've given lesser amount of albumin for these patients to bring about diuresis? Yes, Rakhi.
So thank you for all the questions. And starting with your first question, which was about salt compliance and the salt, what prescription of salt should we be giving to these patients? So I can just say that this is what the guidelines suggest, that we have to put them on 2 grams of salt, but the EASL suggests that we can put them on 4 to 6 grams. But in my practice, I've seen that if you allow them salt, they will be taking a lot of salt over and above what we allow them. So if we, what we should do is to ensure the salt compliance, it is better to put them on a 0 salt and then give them 2 gram salt sachets, so that it is a measured salt that goes into their body. They're not taking any salt in the food. And that way we can be assured of, or we can do a urine spot sodium and we can see that whether they're compliant with the dietary sodium restriction. But what I usually do in refractory ascites is that in the first 1 month, I usually put them on a 0 salt diet, because I know that till I ensure a salt compliance, I will not be able to make a difference. And slowly, once the ascites is still coming under control, then I try and put them on a 2 gram salt intake. And I make sure that they are taking that. And second point, sir, you asked about the
toracamide versus
toracamide, and that's a very that's why. So toracamide may not be the first line therapy, but yes, refractory ascites, wherever we think there are GI issues of absorption, we should never go with furosemide, especially with patients with NASACA, NASH patients who have GI problems, refractory ascites. It is better to go with toracamide because we do see better outcomes with toracamide. And the pharmacodynamics, I did not have time, but I could have shown all these studies on pharmacodynamics and pharmacokinetics of these drugs. There are a lot of good studies on that, comparing these drugs and showing these effects. The third point, sir, which you asked was about albumin therapy. Now, albumin therapy, I feel, it should be the core of management of refractory ascites. How much grams we give has to be individualized per patient. That's my thought on that. I cannot give every patient the same dose. So I will start with an aggressive protocol of giving albumin in refractory ascites and will de-escalate based on the patient's response. So that is what I would suggest, that it should be more individualized rather than protocol based for all patients.
Fine, thank you. Any questions
Yeah, so are you able to hear me?
Anisha.
Yeah, yeah.
Yes.
Yes, that was a nice talk, Rakhi. Congratulations. And I have a few questions and a comment. To start off with, that I really like the emphasis that you put on not the need shouldn't be there for water restriction, because many patients and many physicians who are dealing with ascites invariably along with salt restriction advocate and write for water restriction as well. So that is a very well taken point. A second question is about again albumin. So whereas we have seen that the advantages and the beneficial effects of albumin are not only diuresis, especially I understand we're talking in terms of refractory ascites and in the context of refractory ascites, but then uh, uh, increasing or enhancing the albumin to a certain level so as to see the mortality or morbidity benefits in these patients. I would like you to dilate a little bit on this part. And finally, I would want to know regarding tips, and also for the audience to know that how many patients of tips who required tips, who had refractory ascites, had a low MELD so that a tips could be done rather. So that is a very tightrope walking, and we really don't ever get a situation in which, we have a fine tuning balance in between these two elements.
Yes, ma'am. So your both questions are very valid, and thank you for both of them. So what you mentioned about albumin therapy, so I completely agree. And it is not that we should be relying on IV albumin to bring up the serum albumin levels. So there are a lot of factors. So albumin we know is a negative phase reactant. If inflammation, infection, any other nutritional issues, enterally if the patient is not taking, if the patient is losing albumin in urine. So all the factors should be considered while we are targeting a serum albumin level with IV albumin therapy. So I would suggest that we should not be targeting a serum albumin level. I would target the MAP, I would target the hemodynamics, the overall improvement, the ascites, but I would not target the serum albumin. That is my, and this is what the study from Answer group also, they suggested that irrespective, yes, patients who reach the target albumin, they do very well. But it is not necessary for us to keep pumping on albumin for them to maintain that serum albumin. That is one thing. Second thing, which you said about, I think, Sri, you asked about
Tips.
Tips is also something like when we see patients, the most of the times we see patients very, very advanced, and it's quite advanced in the disease course. So
I guess,
tips, yeah, we have to close this talk.
Rakhi, short
I guess
answer.
so, yeah.
Okay,
So that's fine. Thank you
I'm
so
sorry
much.
for exceeding the time. I'm very sorry.
No, not at all. And then we have our next speaker in the session, invite Dr. Harshad Devrabi, who is going to speaking to us on practical approach for diagnosis and management of DILI. And Dr. Devrabi is a professor of gastroenterology at St. John's Medical College and Hospital, Bangalore. So Dr. Harshad, we could have Dr. Harshad.
Yeah.
Welcome, Dr. Harshad.
Okay. Yeah, I would like to thank the chairpersons for the introduction, and also would like to thank Dr. Kaushal and the organizing team for the invitation to participate in this year's virtual meeting of INASL. Now, why is drug-induced liver injury important? From the regulatory point of view, it can result in drug withdrawal if there is liver injury. From the pharmaceutical company point of view, it can lead to drug attrition, and companies invest a hell of a lot of money in drug development and also in financial losses. From the doctor's point of view, they're exposed to liability risk if the patient thinks that the liver injury is because of the doctor's intervention. The drug companies can go after the doctors, and so do the agencies. But more importantly, from the patient's point of view, it leads to significant morbidity and mortality. If the patient develops LIDI, it leads to, for example, disruption in treatment. For example, in patients who take anti-TB drugs, That leads to withdrawal of treatment, disruption, and leads to drug resistance. So you may find that the patient may die of drug-resistant tuberculosis rather than drug-induced liver injury. Now, hepatocellular liver injury resulting in jaundice can occur from different causes. So when it occurs from drug-induced liver injury, it results in the mortality of about 10%, and this is known as the Hy's law. Whereas if you contrast it with virus-induced liver injury, the mortality is only about 0.02 to 2%. Now, what are the challenges to diagnose DILI? One, of course, it's very underappreciated cause of liver injury, and the clinical features mimic all forms of liver injury. Now, why is it a challenge? Because there is no pathognomonic test to diagnose drug-induced liver injury. It's just a disease diagnosis of exclusion. So because it's a diagnosis of exclusion, we need to rule out all common diseases, like such as viral hepatitis A, B, C, and E, and also it's common bile duct obstruction. Unlike autoimmune hepatitis or viral hepatitis, where you can just do a single test and diagnose diseases, drug-induced liver injury is largely a disease of exclusion. So what is the first step in the diagnosis of drug-induced liver injury? The first step is to consider the diagnosis of DILI in a patient who has raised enzymes with or without bilirubin increase or jaundice, who has exposure to medications, and after you have ruled out all common causes. Now, this is a study that was performed in France, where they had two arms. One is a proactive strategy at 1 week, where there was a centralized screening for AST and ALT. This was seen by a biochemist and reviewed by a hepatologist. And after the 1,400 patients, 7 patients were diagnosed to have DILI. Whereas if you have a standard strategy, that is, patients come to the hospital, they are seen by physicians, referred to hepatologists, then you find that out of 28,000 odd patients, 12 patients were diagnosed to have DILI. And then you find that a proactive strategy picked up 12 times more cases of drug-induced liver injury than the standard practice, suggesting that it's perhaps more common than what is diagnosed. Now, another study, a combination of study, when there's raised enzymes, you need to consider DILI. When there's raised AST and ALT more than 5 times, it could be a non-specific, but that non-specificity is seen in only about 1 out of 1,000 patients. If it is more than 10 times elevation of AST and ALT, it's largely due to ischemic hepatitis, followed by pancreatic biliary causes, and 9% due to DILI. And if the AST ALT is still elevated to more than 20 times, ischemic hepatitis perhaps is more common, followed by biliary, and DILI at about 9%. And if there's only isolated increase in alkaline phosphatase and GGT, the cause is more likely to be biliary or cholestasis or infiltrative liver disease. Now, all of us make a mistake of diagnosing DILI as a default option in patients who have raised AST, ALT, or jaundice. But then we need to have causality assessment to assess or to link the likelihood of a patient's jaundice or AST, ALT elevation with DILI. So you have many causality assessment scores, and I have listed only 2. So we need to take into account the exposure to medications to onset, what happens to the disease course after withdrawal of the medication. We need to rule out alternative causes. What happens after we are rechallenging these patients with the same drugs, whether there are previous reports of DILI, the host risk factors, concomitant medication, and extrahepatic medication manifestations like skin rash, lymphadenopathy, and fever. So you allot a few points, and once you accumulate or assemble a few points, then you can diagnose the likelihood of DILI as definite, probable, possible, or unlikely. Now, this is an important slide, and I spent a few minutes on this slide. A vast number of patients who take drugs do not develop any problems, and they are in the base of this pyramid. A small percentage go on to develop asymptomatic AST and ALT elevation, and these are known as adapters. A smaller percentage go on to develop AST and ALT elevation, which is more than 5 times, but are asymptomatic, and this is still diagnosed as DILI. A smaller percentage go on to develop jaundice, and once you stop the drug, they develop what is called as, they go on to develop what is reversible, clinically significant drug-induced liver injury. A further small percent go on to develop clinically significant acute liver injury with coagulopathy, and only a minuscule go on to develop acute liver failure. Now, one has to look at the background noise that produces AST, ALT elevation. This could also be because of underlying hepatitis B, hepatitis C, or HIV, the concomitant medication that are taken, their patients are taking. And one study done from All India Institute of Medical Sciences 14.7% of patients who developed jaundice and AST/ALT elevation were actually because of hepatitis, viral hepatitis E and A. So these causes, including viral hepatitis A and E and biliary causes, need to be ruled out before you can diagnose DILI. Now, DILI, as I mentioned, can present as acute as well as chronic hepatitis. On the left are listed the patterns that DILI can produce that could result in acute hepatitis, chronic hepatitis, cholestasis, microvascular fatty infiltration, veno-occlusive diseases, and also portal hypertension. And on the right are various drugs that are known to cause these same kinds of pattern. And the commonest ones are anti-TB drugs that produces hepatitis. These are not mutually exclusive, these drugs. For example, hormones can also produce acute hepatitis, but it's unlikely that an INH or anti-TB drug produces cholestasis. So there are three types of drug-induced liver injury. One is the direct type produced by, the classical example is that of paracetamol toxicity, where the incidence is common if you take it in large doses. The latent period is very short, in few hours to a couple of days. The implicated drug, as I mentioned, is paracetamol, and it's because the intrinsic hepatotoxicity of this drug. Now, the second one, which is more important, is idiosyncratic liver injury. And idiosyncratic means idios, one's own, and syncresis means mixture of a personal characteristic. So it's perhaps not because of the drug, but it's because of the person's genetic characteristics that predisposes this individual to develop DILI. So the latent period is about short, a couple of weeks to a few weeks, and that is because you need to stimulate the adaptive immune response to cause DILI. And the drugs implicated, the common ones are anti-epileptic drugs, but in our condition, in our country, it's anti-TB drug-induced liver injury. And the final one that is seen is that, that has been elucidated, are the indirect type of hepatotoxicity. And again, the example is that of immune checkpoint inhibitors or high-dose steroids. And the latent period varies from few months, for example, 2 to 4 months, or even sometimes 7 months. And this is because of the immune-directed action of the agent on the liver or the immune system. In other words, it is because what the drug does rather than what it is. Now, drug-induced liver injury can also present as cholestasis, for if there are drugs such as bosentan and cyclosporin, they can inhibit bile salt excreted protein. That leads to increased bile salts in the hepatocyte. And because increased bile salts have a detergent effect, that produces cholestasis and liver injury. Most drugs that produce drug-induced liver injury have signatures. It's just that sometimes the signatures are illegible. Drug signature could be chronological. For example, some drugs can cause DILI only after a few weeks. It could be biochemical, as I mentioned, AST/ALT elevation rather than alkaline phosphatase elevation. Clinical or immunological. Some drugs can produce immune-mediated reaction resulting in skin rashes, lymphadenopathy, and fever. Histological features, some drugs can have characteristic granulomatous formation, and sometimes it's a combination of all this. For example, drug-induced drug reaction with eosinophilia and systemic symptoms are caused by any of these few drugs that are listed. And these could include carbamazepine, phenytoin, sodium, sulfonamide, nevirapine, and allopurinol. We still see a lot of these drugs, stress reactions associated with drug-induced liver injury because these are first-generation anti-epileptic drugs. They're cheaper. We have large experience with it. And that is why we tend to use this more commonly, resulting in drug-induced liver injury. The drug-induced liver injury is multifactorial. So your patient factors, old age, diseases, female gender that can predispose to disease. The drug characteristics are also important, including chemical structure, molecular weight, the dosage, and the polymedication resulting in drug-to-drug reaction. And also the environment. Patients who are alcoholics, who are malnutrition, are more at risk to develop drug-induced liver. The top 5 causes all over the world. This is the Indian network of drug-induced liver injury, accepted in JCEI. You find that out of 1,288 patients throughout the country, anti-TB drugs constitute almost one half, followed by complementary and associate medicines or Ayush, anti-epileptic drugs, antimicrobial, and NSAIDs. In China, the commonest cause is actually traditional Chinese medicines followed by anti-TB drugs. In USA, it is non-antituberculous microbials that is the most common, followed by herbal and dietary supplements. A few words on anti-TB drug-induced hepatotoxicity. The incidence, as you can see, varies anywhere from 6.4% to 7.3%. And if you lower the bar of definition of DILI, it could even go up to even 10 to 20%. Now, the global burden is about 10.4 million. In India, the incidence is 2.8 million. More men than women develop TB. But paradoxically, more women develop anti-TB drugs than men with drug-induced liver injury from anti-TB drugs. And India is home to almost 1/4 or almost 1/5 of tuberculosis throughout the world. And of the top 9 countries in the world, the top 6 come from Asia. So ATT-induced hepatitis is the commonest cause of DILI. ATT-DILI is the commonest cause of drug-induced acute liver failure. And ATT-induced DILI is the second most common cause of drug-induced ACLF. Now, occurrence of anti-TB drug generally occurs, again, this is a characteristic signature of anti-TB drugs. Most often it occurs within the first 2 months of therapy, although a person is at risk throughout the course of treatment. The timeline of anti-TB drugs, again, a signature 23 to 28 days in median. So what do we do with regard to monitoring patients who have anti-TB drug-induced liver injury? So 2 ways. One is clinical monitoring, the other one is laboratory monitoring. And you have various societies, including WHO, IUATLD, American Thoracic Society, and British Thoracic Societies. Now, briefly, all societies, of course, it is intuitive that you need to stop the drug once you diagnose DILI. So when do you restart DILI drugs? Because it's important that anti-TB drugs need to be restarted as quickly as possible. You restart them when the jaundice settles down or the AST and ALT return to normal, or at least 2 times the upper limit of normal. So how do you restart the drug? Because these drugs are very important and they are first-line drugs. So all these drugs need to be restarted sequentially, not simultaneously. And that depends again, because rifampicin is the least hepatotoxic drug. You give rifampicin first, followed 3 to 7 days later by INH. And pyrazinamide is only started if a person has biochemical DILI without jaundice. So how do we monitor these patients? LFT costs a lot of money. So according to WHO, there's no need to monitor LFT. But according to other societies, you need to at least monitor them, taking into consideration the financial status once in 3 days to once in 7 days. Now, the WHO has this guideline of traditional medicine strategy 2014 to 2023. WHO wants to promote the safe and effective use of traditional medicine by regulating, researching, and integrating these into the healthcare systems of the country. They also have this goal of rational use of appropriate traditional medicine by practices and consumers. Now, we all know there's a lot of resistance to incorporating traditional medicine into mainstream medicine, but the WHO mandates that these need to be taken into account. So they know that there has to be policy regulations. Although we want them integrated, we know that there has to be enough studies on safety and efficacy. And also patients or government agencies that want to promote traditional medicine need to be educated about the ability to control and regulate the outlandish advertising claims that they seem to purport. Now, why is traditional medicine common? That is because it's common. Use of traditional medicine is common because of cultural and historical influences. Even technologically and rich countries like Singapore, Republic of Korea, and China, 76 to 90% of the population use traditional medicine at one form or the other. So needless to say, traditional and Chinese complementary medicine are more common, for example, in Singapore. It constitutes 70% of all cases of DILI. In South Korea, it's 70%, China at 26%. In India and Japan, it's about 13 and 17%. So what about management of DILI? As I mentioned, first we need to take into account that drugs can produce DILI, so prompt recognition and immediate drug withdrawal. Consider the possibility of DILI at all times in patients who present with DILI. Diseases may become worse despite stopping the imputed drug, so one needs to be patient, and there are only very few antidotes with regard to management of DILI. And what are the antidotes? We can use N-acetylcysteine for patients who take paracetamol, who develop paracetamol-associated hepatotoxicity or acute liver failure from paracetamol toxicity. L-carnitine is the antidote for valproate drug-induced liver injury. Cholestyramine is the drug of choice for patients who develop leflunomide-induced DILI. And those patients who develop DILI with hypersensitivity features like skin rashes, lymphadenopathy, fever, those patients, the drugs that produce autoimmune hepatitis producing DILI, and also immune checkpoint inhibitors producing DILI need to be started with steroids. There's of course minimal role or very less evidence for UDCA plus or minus steroids for patients with DILI. Now, last few slides, so we have this intravenous N-acetylcysteine improves transplant-free survival study published in Gastroenterology a few years ago, but only in those patients with DILI who had stage 1 and stage 2 or coma grade 1 and 2, where it improved the overall survival and also the transplantary survival. Leflunomide hepatotoxicity, and this is I want to highlight, even though you stop the drug, the active metabolite stays in the circulation for up to 2 years. So one needs to give oral cholestyramine for at least 11 days. So L-carnitine is, as I mentioned, again, a small study published in neurology a few years ago. And then again, anecdotal reports, including some case reports of the beneficial effects of steroids and ursodeoxy of folic acid in patients who developed severe drug-induced liver injury, particularly in those patients who have developed cholestasis-induced liver injury. So in conclusion, first step in the diagnosis of DILI is to consider DILI at all times. DILI is largely a diagnosis of exclusion, so we need to rule out competing causes because we have no pathognomonic diagnostic test for DILI. All drugs, and if you study very carefully, have drug-specific signatures. It could be with regard to latency, it could be with regard to clinical features, histology, so one needs to master that. Anti-TB drugs and traditional and complementary medicine, or in our country, Ayush, are the top 2 drugs causing DILI. Prompt identification and cessation is the keystone of treatment of drug-induced liver injury. And there are only few antidotes that are present for the diagnosis of drug-induced liver injury. Thank you very much for your attention.
Thank you, Dr. Harshad, for the very illuminating talk and very lucid talk. There are some questions in the Q&A window, Dr. Sethu Babu, Dr. Jayanti. Would you like to take them up? And
Yeah, sure.
Yeah.
So we have 5 minutes, I'll take them up.
Please. So probably the question.
You'll have to tell me the question.
Yes. So Dr. Sethu Babu wishes to know about the dual issue of rheumatic and connective tissue on medication developing DILI. So you might need a biopsy. He wishes to know at what point in time a biopsy may be needed. And Dr. Jayanti, probably once you answer this question, then I'll come to the next one.
The biopsy is rarely helpful in patients who have drug-induced liver injury. In patients, for example, who have rheumatological diseases, there are few drugs that produce. So as I mentioned, if you are taking a drug for years, that is not DILI. So when you have started a drug and then a patient develops drug-induced or altered liver function test within the next few weeks or few months, then it's more likely to be DILI. So when you have 2 drugs, for example, let's say you have 5-aminosalicylic acid or sulfonamides and some azothioprine producing DILI, then again, each of these drugs has got a signature. For example, sulfonamides will produce some skin rashes, lymphadenopathy, fevers, so you need to stop sulfonamide. Whereas with patients who develop azothioprine induced, it's more of cholestasis. So again, what you rely on these signatures, then it's very rarely that you require liver biopsy. Liver biopsy is helpful when you have diagnostic confusion. It's helpful also in prognosticating. So if you have increased or large amount of necrosis, then you know these patients are going to do worse, and these patients need to be followed up very carefully and perhaps also referred to a place which has liver transplantation.
Yeah.
Whereas if you see a patient who has only granulomas, very little necrosis, and some cholestasis, then there's more likely that this patient will recover from drug-induced liver injury.
Okay. So probably we go to the next question from Dr. Jayanti, and this is something which has crossed my mind as well. How long does post-amiodarone withdrawal, how much time does it take for the liver biochemistry to settle? It's a chronically, damaging drug. So we do come across such patients. You could quickly answer this, and there's one more question in line, but I'm not very sure about. So kindly be brief, Dr. Harshad. Yeah. Thank you.
So with amiodarone, if you are lucky, and if patients have taken only for a short period of time, especially, for example, when you give amiodarone for control of ventricular tachycardia, there's a good chance these patients will recover. But if you're given it for chronic heart failure, including arrhythmias for months, there's less chance that this patient will completely recover. There will be some amount of liver damage that will persist. So it depends again. There's lots of patient variability that also plays a role, along with the amount of drug that a person has taken. So the cumulative dose is also very important in addition to in how you can prognosticate lesions with amiodarone drug-induced liver injury.
Yeah. Dr. Abha has a similar question. Do presence of eosinophils in the biopsy suggest DILI?
Yeah. So, if you look too hard in liver biopsies, you can find eosinophils all the time. So again, it has to be significant. And again, astute pathologists will probably tell you that these eosinophils that one sees are not the common garden eosinophils that one sees, but probably is because of some immunoallergic reaction. So again, eosinophils, but the good thing about eosinophils, just as when you have peripheral eosinophilia, the prognosis is good, liver eosinophilia also prognosticates well, and the patients actually will do well with eosinophils.
Thank you so much. There are some questions coming up, but I'm sorry we won't be able to take them up. Thank you, Dr. Harshad and Dr. Rakhi and Dr. Chawla, sir. Sir, you could perhaps wind up the session. There's a message coming in from Dr. Kaushal to go to the next session. Yeah.
Thank you.
Sir, you'll have to unmute it. Sir, Chawla, sir, you'll have to unmute it.
Dr. Chawla, we can't hear you.
Yeah. So is he able to hear you? Okay, no problem.
Okay, I think thank you very much for all the to all the chairpersons and speakers for a wonderful talk and a wonderful conduct of this session. And thanks to our course directors, Dr. Pankaj and Dr. Rakesh Agarwal, for making such a fantastic program for the PG course. So we move on to the next session, which is
thank you. Yeah.
Thank you so much. We move on to the next session, which is on orations. Before that, I just have a short announcement that for the delegates who seek to get a participation certificate, they will be able to download it from the virtual platform if they go into the exhibition hall, but only on day 3 once all the sessions are about to be over, they will be able to download their participation certificate. So let's move on to the next session of orations. For this, I would like to invite the chairpersons, Professor M.P. Sharma, who's currently the chairman of Gastroenterology and Hepatology at Rockland Hospital, New Delhi. He was earlier the head of the Department of Gastroenterology and Hepatology at All India Institute of Medical Sciences. Dr. Ramesh Rooprai, who's currently the senior gastroenterologist and head of department at Fortis Hospitals, Jaipur. And earlier he retired as head of Department of Gastroenterology from SMS Hospital, Jaipur. And Dr. J.B. Dilavri, who's currently the Director of Gastroenterology and Liver Diseases at M.I.C.E. Hospitals, Mohali. And he was earlier the head of Department of Hepatology at PGI, Chandigarh. So over to the chairpersons, please.
Good evening. This is Dr. M.P. Sharma. Sorry, I don't see my face. It doesn't matter. Can you hear me? Can you hear me?
Yes, sir, we can hear you, sir.
I can see you.
Can you see me?
Sir, please start your video. Yeah. So please start your video.
Can I start? Dr. Kaushal?
Yeah, Dr. Dilavri, please start.
Okay. Well, good evening to participants in India, and good day to the participant in Europe, and good morning to the participant in America. Mahesh, I can see you now. And
Okay, thank you.
We'd like to thank INASL and Dr. Kaushal Madan for inviting us to chair this prestigious orations. Let us start with Professor Madan Gopal oration. My association with Dr. Madan Gopal goes back almost 40 years, when he invited me as visiting professor to Madras Medical College to teach and perform ERCP. Dr. Madan Gopal, Doyen of Gastroenterology, was regarded as the rising sun from the south. He established the very first department of gastroenterology in the south in 1971. One of his students, Dr. Jayanti, tells me that Professor Madan Gopal commuted to hospital by bus. And I think this shows his humility and empathy for the common man. He was a dedicated teacher and believed in nurturing the best out of his students. His teaching ward rounds, particularly on Sunday morning, was so popular that it attracted a large number of students from various institutions in Chennai. His passion for research knew no bounds. Published more than 200 articles in prestigious journals. His main interest of research was in the carcinogens of hepatocellular carcinoma, subacute hepatic failure, which we now call acute and chronic liver failure. Budd-Chiari syndrome, he in fact coined the term coarctation of inferior vena cava with his surgical colleague Victor Salomon. Professor Madan Gopal was honored by both our societies, president of ISG in 1975 and president of INASL in 1988. I now invite Professor M.P. Sharma to introduce the speaker for this memorial oration. Professor Sharma, please.
Thank you, Professor Dilavri. I have a great pleasure in inviting Professor A.C. Anand, who has been a long experience in the clinical gastroenterology and hepatology. He has served in the army for a very long time and rose to the award, became the Lieutenant General of the Indian Army. He was given a lot of awards. If I start just enumerating his awards, I think I will take half the hours. So he was only two things to remember, that he was given the Vishesh Seva Medal from the President, which is the highest award. And also he was the President of Indian Society of Gastroenterology and Indian Society and Study of Liver Disease. He has published as a keen researcher, and he has published more than 370 publications. I have the honor, will say I have the honor that he did TM with us. And at that time, he was one of the finest students I have ever come across. He was always ready for the answers, and taking ward round with him was a pleasure. And also, I'll all remember one more thing about Dr. Anand, that he has been a very pleasant personality. Everyone who came in his contact, all the patients were so happy to have him as their teacher and and also the physician. I have great honor and pleasure to invite Dr. General A.C. Anand to deliver his oration, Madan Gopal oration on Sai from Siachen. Professor Anand, please.
Thank you, sir. Is my voice reaching you?
Yes, thank you.
And I'll just share my screen. Can you see my screen?
Yes.
Thank you very much, sir, for that very kind introduction. This oration is a great honor for me, and I'm grateful to INASL for giving me this opportunity. I remember Professor Madan Gopalan as a great teacher, an astute clinician, and an innovative researcher. As for me, most of my life I have worked with armed forces, and I wish to dedicate this talk to our brave soldiers. I'll be sharing with you a slice of their life as first part of this presentation. This is the outline of my talk, and I'll begin with a brief preamble to the journey of our index case, which has led us to make a new discovery, and the follow-up research that we have done. In the second half, I will talk about the current concepts and management of this condition in 2020. What you see in the background here is a satellite picture of Himalayas, where all this action took place. For the doctors in Army, a tenure in high altitude is the real indoctrination to service ethos. Here, battling the enemy is a minor problem for soldiers. Surviving the fury of nature is the biggest concern. And the main action for this patient was here. As we go up in the mountains, the partial pressure of atmospheric oxygen falls, and heights above 3,000 meters are considered high altitude, and those above 5,000 meters are considered extreme altitude. And over the period of extreme altitude, one requires supplemental oxygen at places. Indian Army is holding many positions above this extreme altitude area, and the stay in this area is associated with several illnesses because of altitude as well as sub-zero temperatures. Acute mountain sickness is a common nuisance condition that affects over half the people who are climbing above the 3000 meter area. Altitude related pulmonary and cerebral edemas are less common but can be lethal. This talk is about a new complication that we discovered in this area. As you would have guessed from the title of this talk, we are going to talk about CHN, which is behind this panel. Can I reduce the panel? CHN is different from Galwan Valley, which has been in the news recently. It is a 700 square kilometer glacier which lies as a wedge between the area occupied by China in the southwest and occupied by China in the northwest and by Pakistan in the southwest. There are no highways in Siachen. It's an area which is very difficult to get to, and it takes up to 15 days of punishing trek to reach many army posts. The route passes over massive sheets of ice with deep crevices several meters deep, and they are lying between the big ice plates, and it is dangerous to cross them at times. Avalanches are common in this area, and this is a recent picture of an avalanche taken from a distant mountain. Various features in Siachen are named to honor the soldiers who lost their lives in this battleground. Our story will start from one of these posts. Our index case is a brave heart, 35 years old, in a state of robust health, deployed at 5,800 meters height for previous 9 months. He is a teetotaler, and the picture that you see on the right of this slide is from one of his archives that shows happier times before he went to Siachen. The story began in the year 2000 on the New Year's Day as India was battling to evict Pakistanis from several heights. He developed moderately severe pain in upper abdomen, but as an officer in charge of that sector, he underplayed his symptoms and decided to wait for improvement. But when the pain became more severe and he had a black tarry motion, he was ordered to be evacuated. Evacuation from this area is easier said than done. The post was in perpetually bad weather, and hence he was taken down to another post little lower down on Manback. Even from here, again due to bad weather and partly due to tactical reasons, it took another 7 days for chopper to evacuate him to a field hospital at the height of 4,250 meters. At the field hospital, the doctor suspected that it may be acute pancreatitis and advised him to be taken out of Siachen sector. Subsequently, he was flown to Chandigarh, where our team was located, and we did a clinical evaluation and found that there was free fluid in abdomen and a large tender lump in left upper quadrant over the splenic area. Investigations showed that he had marked leukocytosis, and his peritoneal fluid turned out to be hemorrhagic. Doppler ultrasound showed that hepatic artery and hepatic veins were normal, but portal, splenic, and superior mesenteric veins were completely thrombosed. CT scan confirmed thrombosis of the complete portal system and showed significant bowel edema and a large splenic hematoma. Pancreas, however, was normal. So the real problem was that there was acute thrombosis of complete portal system leading to bowel ischemia and congestion with large splenic hematoma. He was resuscitated and stabilized and subsequently heparinized. Once he was clinically stable, he underwent resection of the ischemic bowel and splenectomy, after which he steadily improved. He was later discharged on oral anticoagulants. By the time of his discharge, he had already developed ultrasound features of portal cavernoma and endoscopic features of small gastric varices. Hence, beta blockers were also added to the treatment. At that time, we had no clue why this gentleman had developed portal vein thrombosis, and we started looking at our hospital statistics. We realized that during the period of Op Parakram, it's about 8% of patients in our hospital, 8% of patients in the hospital had developed, were evacuated from the extreme altitudes, and there are only two routes of evacuation from that area. One route is by air, which went directly to Chandigarh, and the other route is by road, which went to Udhampur near Srinagar by road. And we started looking at our own hospital statistics, and the major legwork was done by two young interns at that time, Dr. Manish Manrai and Dr. Kavita, who diligently sifted through all the physical files. We like to believe that this project brought them together as they got married later. Manish is now Professor of Gastroenterology and Kavita Professor of Radiodiagnosis at Armed Forces Medical College. The other members of the team were a rheumatologist, a neurologist, a GI surgeon, and a radiologist. We found that at that time we first looked closely at the thrombotic events that were present in less than 50 years of age group, and we discovered that incidence of thrombosis was among the soldiers coming from the operational area was nearly 30 times higher as compared to those coming from the plains, and this difference was highly significant. Then we started looking at each diagnosis separately. We found that deep vein thrombosis was 50 times more common among the people coming from high altitude, and we found the strokes were 15 times more common. Pulmonary thromboembolism was 75 times more common, and portal vein thrombosis was more than 100 times more common as compared to people who were coming from plain areas. Almost all these patients were recalled later for re-evaluation for thrombophilia, and all the patients who had portal vein thrombosis were negative for thrombophilia. All our patients, we noted, had developed portal cavernoma over a very short period, earliest 3 weeks and latest by 6 months. And 5 of the 8 patients at that stage had required surgery due to bowel ischemia and large splenic hematoma, while 3 had improved on conservative treatment. None of our patients had detectable thrombophilia, as I said earlier. There were no precedent cases or case reports of similar finding in extreme altitude earlier. It was suggested that dehydration could be one of the factors, as the area has sub-zero temperatures, zero humidity, and very high condensation. Water is difficult to come by in that area due to perpetual shortage of fuel, and to add to it, there are periods of prolonged immobilization due to the tactical requirements of the job that soldiers perform. Some of the people suggested that tight belts may be contributing, but we realized that no one wears belt in that area. Polycythemia of the altitude with increased viscosity is surely a possible contributing factor. Very little research has been done in this area in the extreme altitudes. There are only few reports of mountaineering expeditions lasting 4 to 6 weeks, and that too mainly in the high altitude area, and therefore we decided to undertake a new study. And we decided to follow one company strength of troops, that is about 120 people, through their induction into Siachen. This area has very high attrition rate, and by 8 months that we analyzed, only 68% of all troops were available in the extreme altitude. And a colleague of mine did a series of blood tests to show the coagulability of the blood at the time of induction, after 3 months as they entered the extreme altitude, and after 8 months. And we realized that there was progressive increase in platelet counts, fibrinogen levels, platelet activators, and beta thromboglobulins with prolonged stay at extreme altitude. These findings were published later, and since this paper was published, we had restricted the tenure of Siachen stay to 6 months for our soldiers. We subsequently traced and analyzed all cases of portal system thrombosis that were seen in both the command hospitals and a few that were evacuated directly to Army Hospital RNR. Profile of patients coming from high and extreme altitudes were very similar, but it was different from those who had portal vein thrombosis in the plains. Soldiers from the high altitude were younger, had more extensive thrombosis, rarely had thrombophilia apart from prolonged stay at extreme altitude, and none of our soldiers had died or required endoscopic variceal ligation. Portal vein thrombosis patients coming from the plains were older, often had background thrombophilia, and some even had cirrhosis. 7 out of the 13 patients were treated with endoscopic variceal ligations, and 3 of these died during follow-up period. These findings were subsequently published. Let me now switch gears to tell our young friends what is the current concept about management of portal vein thrombosis as we practice in 2020. Dr. Sareen has given us a very useful classification of this condition in 2016. We classify portal vein thrombosis as per the anatomical site of thrombus in the portal vein, as per degree of occlusion, as per duration of symptoms and the presentation, extent inside the portal system, that is whether splenic vein and the superior mesenteric vein are also involved, and whether there is an underlying liver disease like cirrhosis or hepatocellular carcinoma. Patients who have cavernoma are considered chronic portal vein thrombosis. As we all know, the risk factors for portal vein thrombosis can be classified as systemic or local. There are a large number of systemic causes of thrombophilia, and we have been able to add one line here: prolonged stay at high altitudes. There can be many local factors responsible, for example, intra-abdominal infections, pancreatitis, surgery, liver transplantation, TIPS, or even portosystemic shunting, abdominal trauma, and tumors. And lastly, we have a group which we commonly see, that is sluggish blood flow, as in cirrhosis and portal hypertension. And this is the group which I'll be discussing a little separately. The clinical presentation often depends on the predisposing condition. If the cirrhosis and hepatocellular carcinoma are present in the background, the patients often will present with ascites and variceal bleeding. But in non-cirrhotic patients, occlusive as well as non-occlusive thrombi can sometimes be asymptomatic, but more often they are present just as our index case had presented. If the bowel wall is compromised, perforation and peritonitis can follow, which can be fatal. Color Doppler is the screening test of choice. American College of Gastroenterology has brought out clinical practice guidelines earlier this year, and they recommend CT angio or MRI as a definitive test of choice to determine full damage not only to the portal system but also to the intestines. It has a sensitivity of nearly 100% to detect portal vein thrombosis. The tumor thrombus due to hepatocellular carcinoma may be suggested by arterial enhancement in the thrombus besides other clinical and ultrasound Doppler signs. Now, anticoagulants are universally helpful for patients with acute portal vein thrombosis. It helps even in asymptomatic cases. A study on 95 asymptomatic cases showed that portal vein patency could be increased by anticoagulation from 13 to 33%, and superior mesenteric vein patency from 42 to 73%. Even in symptomatic patients, anticoagulants can be very useful. It prevents bowel ischemia, reduces hospitalization, and improves survival of these patients. Usual duration that is required to be given is about 6 months, but if inheritable thrombophilia is detected, probably a lifelong anticoagulation would be required. In chronic portal vein thrombosis, if there is an inheritable thrombophilia, there is a progression of thrombus, or there is evidence of bowel ischemia, anticoagulants can also be given in this group. Now, which anticoagulant should be used? In acute stages, unfractionated heparin is preferred over low molecular weight heparin because of their quicker onset of action and shorter duration of action, higher efficacy, and lower risk for heparin-induced thrombocytopenia. At the time of discharge, ACG recommends old-fashioned warfarin over newer direct-acting agents because of easy availability of an antidote and a monitoring test which is available very widely. Thrombolysis in the portal vein is also feasible, and either it can be done directly through the indirectly through the superior mesenteric vein or directly via a catheter introduced transhepatically. A systemic study of 71 patients is available where it had several other different techniques have been used. The results have been very mixed and all the observations are uncontrolled. Major complications were recorded in about 60% patients, and therefore this form of treatment is not recommended universally. Surgical thrombectomy has also been done in many patients who have required a small intestinal resection due to bowel ischemia. However, these are all uncontrolled and isolated case reports, and therefore too little evidence is available to make any recommendations about surgical thrombectomy. Chronic portal vein thrombosis may present with cavernoma cholangiopathy. An example with biliary stricture is shown here. These patients can be treated with ERCP to remove intraductal stones and placement of biliary stent. Surgical decompression by a portocaval shunt can also help these patients. Now, for this reason, portal vein thrombosis in the background of cirrhosis is an entirely different disease. Sluggish flow in the portal vein is a major contributor. Apart from that, coagulant and anticoagulant, both factors are deranged, and therefore the conventional tests of hemostasis cannot predict the tendency to form thrombus. In addition, sometimes presence of sepsis, hypothermia, or kidney dysfunction can shift the balance in either direction, either towards inappropriate clotting or bleeding. It's particularly in the decompensated stage. And therefore, for this reason, fresh frozen plasma to correct INR should never be blindly given in cirrhosis without checking thromboelastography. It is not only adds to the volume, but may also precipitate portal vein thrombosis. Incidence of portal vein thrombosis is high, and it may occur in about 10% cases during first year of follow-up, 20% cases in 5 years follow-up, and about 30% cases in about 10 years follow-up. Spontaneous resolution and regression can occur in over half the cases, but in about 12% the thrombus may progress. In the presence of cirrhosis, stable and asymptomatic cases may not be treated with anticoagulation, but one must evaluate the risk of bleeding and injury to the patient if there is any encephalopathy before thinking of anticoagulation. It is often difficult to differentiate between recent and chronic cases if the varices are already present due to cirrhosis. Hence, the anticoagulation must be given to all symptomatic cases. For complications of portal hypertension, non-selective beta blockers, endoscopic variceal ligation, TIPS, or transplantation can be considered in selected cases. Therefore, I like to conclude by saying that prolonged stay at extreme altitude leads to thrombophilia and can precipitate portal system thrombosis. Portal vein thrombosis can also be seen in several other thrombophilic conditions and may present acutely with pain which is disproportionate to clinical signs, followed by fever and melena. Doppler ultrasound for screening and CT angio for definitive diagnosis are investigations of choice. Preferred therapy includes unfractionated heparin in acute stage, to be overlapped till the effects of vitamin K antagonists take over. Experience with thrombolytic therapy and surgery is very limited, and therefore they cannot be recommended. Cirrhosis with portal vein thrombosis is an entirely different disease, more often presents as decompensation, that is with variceal bleeding or ascites. Patients with child's A and B cirrhosis should be considered for anticoagulation. All patients should be carefully evaluated to assess risk of bleeding before considering anticoagulation, and the patients with chronic portal vein thrombosis can also be considered for anticoagulation if there is thrombophilia or evidence of thrombus progression, and anticoagulation therapy, however, should only be given after prophylactic treatment for varices. In the end, I would like to thank INASL once again for this opportunity and to audience for the patient hearing. Thank you very much.
Thank you, Dr. Anand.
Thank you, Professor Anand, for giving a brilliant oration and combining with your high altitude experience and bringing it down to the garden variety of portal vein thrombosis, which we see every day here. It is customary not to ask any questions for the oration, so we now go on to the second part of the oration. And now for presidential oration, I invite Professor Ramesh Ruproy to introduce the speaker, Professor Rakesh Agrawal.
Thank you very much, sir. It is my pleasant and privilege to invite our dynamic president INASL, Professor Rakesh Agrawal. Professor Agrawal is Director and Professor of Gastroenterology at Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER, Pondicherry. Before this, he worked for 28 years in Sanjay Gandhi Institute of Postgraduate Institute of Medical Sciences, Lucknow. Besides obtaining his formal training in gastroenterology and hepatology, he has received formal training in epidemiology and laboratory work. The primary area of his research work over the last 3 decades has been viral hepatitis, including epidemiological, laboratory, and health economics aspects of hepatitis E, C, and B. He is a member of several national and international bodies, including WHO Scientific and Technical Advisory Group on Viral Hepatitis, WHO Strategies Advisory Group of Experts on Immunization, National Technical Advisory Group on Immunization in India, and National Expert Group on COVID-19 vaccination. I have got a lot of fond memories of him when we were at All India Institute and he was doing his MD. I always appreciated his scientific knowledge, but more than that, he has his dareness to express his views on any scientific discussion, and he is still maintaining that. He has recently completed his 2 years term as president of Indian Association of Study of Liver, and it is my present duty to invite him for his presidential oration. Dr. Rakesh Agrawal.
Thank you, Professor Rai, and thank you, Professor Dilawri. It's been an honor to be the president of INASL for last 2 years. I finished my term a few weeks ago. INASL has been such an important part of my life for several years. I've gained so much from this organization. It has given me so much. And so when I have to choose a topic for my presidential oration this time, there were several things in my mind, but I think choice was made by the recent announcement of Nobel Prize for the discovery of hepatitis C virus. And these are 3 gentlemen whom I have had the occasion to interact with at different times of life. And what they have done is they've done 3 sequential steps in proving that hepatitis C is the cause of liver injury. And I'll briefly allude to each of these and then go on to how life in my lifetime, everything has changed about hepatitis C. That's the first time that hepatitis C was suspected. A paper in Lancet, 1975 by Dr. Harvey Alter, where it's a case series of 12 patients who had post-transfusion hepatitis, multiple transfusions received for open heart surgery, a few weeks later hepatitis, and a test for hepatitis B had just become available, so had a test for hepatitis A, and they found that of these 12, only 4 had hepatitis B virus infection, and 8 had neither hepatitis A nor B. And they coined that term that people of my generation are familiar with, non-A, non-B post-transfusion hepatitis. And that's where the story began about 35 years ago. However, they didn't sit on that. And through painstaking efforts, he did a lot of work. And 3 years down the line was this paper, again in Lancet, where they inoculated plasma from patients with acute as well as others with chronic non-A, non-B post-transfusion hepatitis into 5 chimpanzees, and we can see their results on the right. And they showed that ALT and AST levels went up. In the same paper, they show liver biopsy tissue from chimpanzees and showed that they developed liver inflammation. And that was a demonstration that there was something in the plasma that could transmit hepatic inflammation or hepatitis. So one more step taken, but that's where we were. They did find out by filtration some physicochemical and many other experiments, physicochemical characteristics of these putative virus at that time. And then the second step was taken by the group from Dr. Michael Houghton at Chiron Corporation. They screened a cDNA library, making 1 million clones and painstakingly screening each of those with serum from a patient with fulminated hepatitis B. Their idea was that these million clones will produce different proteins. And if in one of those clones, a protein from hepatitis C, at that time known as non-A, non-B, was being produced, it would react with the antibodies in the patient's serum and produce a band. And they were lucky. This was a new technology. Out of 1 million clones, they found one, which did not have chimpanzee or human DNA sequences, and it hybridized to a positive strand 10,000 nucleotide RNA, which today we know as hepatitis C virus RNA. Using this protein and putting it on membranes, they could show that in patients with post-transfusion hepatitis, their sera did not show any reactivity on day 9 and day 71, but from two other patients, when the specimens were collected on day 118 and 154, they could show that there was reactivity, indicating that there were antibodies being produced for this protein, and this permitted the development of a diagnostic test. So that was the second step in the story. And finally, another nearly 20 years later, Dr. Charles Rice's group, they took a nucleotide sequence, a complementary DNA corresponding to the RNA of the hepatitis C virus, made synthetically, and they injected it into the livers of chimpanzees, and they showed that the animals developed hepatitis, they had histological changes, and they had circulating HCV RNA in their blood, and again, from them, the disease could be transmitted further. So that completed the third set of experiments, and we had a proof that it was this RNA or RNA of the virus hepatitis C. So that showed that hepatitis C virus is the cause of disease, and there is nothing else that is causing this disease. Once diagnostic test was developed by the Chiron Corporation, by Michael Houghton's group, we very soon worked out, and we found out that in normal liver, there is an acute inflammation, acute infection, and then a large proportion go on to develop chronic infection, they get cirrhosis, and they have liver cancer. And the risk of this progression is much higher in men than in women. And when the infection occurs later in life, and in those who are taking alcohol or have co-infection with other hepatotropic viruses. And that's the part of the world where this infection is seen the most often, with red areas showing a high frequency, highest being in Egypt, and other high incidence areas or high prevalence areas in our neighborhood are Pakistan, Mongolia, and also the USSR. So with this, drugs were developed. Once the Charles Rice group showed that one could take the RNA, the complementary DNA corresponding to HCV RNA, and cause infection. However, the problem with that model was that chimpanzees were difficult to use, and complementary DNA did not cause infection in cell lines. However, that gave a clue, and other groups developed shorter segments of subgenomic RNA, which could be which could replicate in cell lines, and that provided a model for developing drugs. And drugs were developed against several proteins of hepatitis C virus, in particular the NS3 protease, NS5A replication complex inhibitor against NS5B, and a large variety of drugs were developed, but in India we actually have only 4, but even that is adequate. So once these drugs were developed, it was found that these were wonder drugs. in people without cirrhosis, they could cure infection in 95 to 99% of people. Among persons who already had liver cirrhosis, this efficacy was somewhat lower, but still very good. And coexisting conditions, some of them which are risk factors for hepatitis C, some of these associated with immune suppression, some of disease, other comorbidities that affect survival, but none of these seemed to take away the good effect of these drugs. And even in these complicated cases, the treatment was very successful. That opened up the thought that we could think of eradicating HCV infection from the world. What is eradication? Eradication is permanent reduction to zero of the incidence of infection caused by a specific agent. This has to happen worldwide as a result of deliberate efforts. And once we achieve this, then we do not need any intervention for that infection. We have achieved that for smallpox. In India and many countries, we have achieved that for polio, but because it persists still in some parts of the world, so we still need to continue intervention measures, that is polio vaccination. So can we do that with hepatitis C? When people started looking at that, there were many things that were favorable in favor of eradicating hepatitis C. There is no reservoir outside humans. It does not multiply in the environment. One can diagnose those people who are infected using a lab test. But some things were against. This disease, this infection is associated with a chronic infection, and that is something which is not good if we want to eradicate a pathogen from the earth. Also, we did not have a vaccine, but we had very effective drugs, and that was, that takes away the fact that we do not have a vaccine. And we do have some drug resistance, but that is again infrequent. However, the major challenges are economic and political and social, and that's why I'm using this platform to draw your attention to some of these, and these are going away, but still we need to do a lot of work. So the world decided that we cannot possibly eradicate, but we can try to eliminate infection. Elimination is not the same as eradication, but fairly similar. So we reduce the disease frequency, not to zero, but to below a certain threshold, which is very close to zero. This is basically in a defined geographical area. And because the infection is still present in the community, in the population, or at least in some other populations around the globe, continued intervention measures may be required. So this is what we have done for neonatal tetanus. It's extremely infrequent in many parts of the world, but still, because the pathogen is in the environment, it is present in soil, we cannot eradicate that infection, and we need to have continued intervention measures. So what has been done is the target being to eliminate viral hepatitis, not totally, but as a major public health threat, and which is something that the whole world is working. We are wanting to reduce new infections of hepatitis C, and for that matter also of hepatitis B, by 90%. That is below the threshold, below the level that we had in 2015 by 2030, and also reduce the number of deaths due to hepatitis C by about 2/3, that is 65%. So what were the problems? The problems have been, one, that the drugs are costly. One was not sure whether the treatment is cost effective. We needed genotyping. We need to diagnose these cases and treat them. And if we have to treat a large number of people, we need a large trained healthcare workforce. Cost and cost effectiveness. We in India do not realize the cost because for us it is cheap, and so are these drugs cheap in many parts of the world. But of course, it has taken effort to achieve that. But even if it is cheap, with the number of people being needed to treat, the question is this cost effective? And we and many other groups around the world have done this work. And using this work in India, we were able to show that if these drugs are used in India, by treating all patients of hepatitis C, the original paradigm was to treat those who had cirrhosis, but we were able to show that even if we treat those who do not have cirrhosis, on an average, they would gain about 4 years of life if they are treated at the age of about 35. And this would cost some money in the beginning, but in the long run, because no liver disease would happen, actually the ultimate expenditure over a lifetime will be in negative, which means the treatment would be cost saving. So the cost saving was much more if you treated people with liver cirrhosis, and these 3 dots indicate different genotypes as shown here. But even if people don't have cirrhosis, we were able to show the treatment would be cost saving. This work helped expand and helped the government of India deciding that it would start on a hepatitis C treatment program. It has been initiated. It hasn't spread as well as it was supposed to, but in the next 1 or 2 years, that's going to happen. We were able to show that the expenditure that you make in the first year for treating is paid back over time, overall by 10 years. But if you look at people with cirrhosis, that happens even before 5 years. So if you invest in treating a person with cirrhosis today, all the expenditure that you made would be paid back within 5 years. So now today we have generic DAAs available in several countries around the world, and that one problem has become clear. And now since 2019, WHO also recommends that treatment for hepatitis C should be done irrespective of whether cirrhosis is present or not present. The second challenge was genotyping, and this genotyping is a problem because it means that we need a lot of lab capacity, and that's not available in the periphery. Again, we have tried to look at this issue, and we think that this work and work from some other groups again has played into developing WHO guidelines. In this paper, we were able to show that if you use velpatasvir instead of the other drugs, in combination with sofosbuvir, then the treatment in fact is cheaper and cost saving as compared to testing, because this is a pangenotypic regimen, compared to doing genotype testing and then treating based on the genotype that is found. And so now these regimens are being used more and more, and WHO guidelines refer to our work and they recommend that there should be genotype independent regimens should be used. The big challenge that remains are 2. One is to find patients with hepatitis C virus infection and linking them to treatment. So if this is the number of people that need treatment in different WHO regions, each shown by a different color, this is the target. By 2030, we need to treat 90%. However, around the world, this proportion remains very small of those who have been diagnosed and those who have been started on treatment or cured. The basic problem with diagnosis is that these people are mostly asymptomatic. So either you test everybody in the population, or you need to find out which is the group that we can test. In the US, they have found that those people who were born between 1945 and 1970 are the ones who have a high frequency. People born before those years and after those years have much less frequency. So that is the group that has been screened, and then if found positive, subjected to treatment. In other countries, Egypt, it is people above a certain age group. So so it appears that up to a certain time point, there was a very high rate of infection in the community, but those who have been born in the last 20-25 years do not have as high an infection rate, and they are testing all the elderly. In our country, that remains a problem. We don't have very clear idea of who are the people who are at a higher risk of having an infection. The best predictors appear to be the fact that a person had received blood transfusion in the past, people who give history of injecting drugs, and then certain special groups that are listed on this slide. Age-based cohorts is unlikely to work for our population, and general population testing would be just too costly. However, there are things that we can do to make diagnosis and treatment better. Some of these are happening, but they haven't caught on as much as one would have loved those to. We need to have more point of care tests being used. There are antibody tests available for saliva, and that makes testing much easier. You don't have to prick a person. Also, that reduces the plastic waste in the form of syringes taken used to draw blood samples for large-scale screening. And if we can catch these people, and also we can do capture people whose blood sample is being drawn for any other purpose, for instance antenatal women or other groups, then one should test those. Also, tests are being developed for dried blood spots. They are extremely effective. Some of them have been shown to be very useful, but they are not being used. This would help because we could then collect specimens in the periphery, transport those to a central lab and test them. They are very well suited for screening. Antigen testing, something is that is useful for public health purposes, because then you do not have to do a two-stage testing, which means first you test a person for antibody, and if positive, then you send a specimen for RNA. With that, a lot of people who have the first test done do not return for the second test, and that's a problem. And secondly, molecular tests are not as easily available. They are costlier. They need specialized equipment. They need specialized manpower. So antigen test is useful. Still, treatment regimens depend on whether a person has cirrhosis or advanced fibrosis. Transient elastography is costly, is not available everywhere, and we need to move over to simpler things such as APRI. And finally, we seem to think that patients need to be tested repeatedly during treatment, and that is something that we hepatologists need to work on to change the understanding that we don't need to do testing repeatedly while treatment is continuing or at the end of treatment, and testing needs to be done only once a person has completed 12 weeks or maybe 8 weeks after the end of treatment. And finally, we need healthcare workforce. To treat the number of people who are in our country. So in our country, it's expected that there are about 7 million people infected with hepatitis C. If we divide that by the number of hepatologists that are available, or for that matter, internists who are interested specifically in liver disease, we would take a too long a time. We'll take decades to treat everybody. So we as hepatologists need to work to train general physicians and maybe even people who are MBBS in treating hepatitis C virus infection. The drugs are fairly safe, and only then at the societal level will we be able to make a change that we are capable of today. If we have to translate the advantages of what these Nobel laureates have done or their work has made possible, in 35 years, we have such a good cure from the time the disease was first suspected. I'm not even saying first proven, first suspected. It is our duty to carry these benefits to the population. We need to work as public health people rather than just hepatologists. And we can do this only if we transfer our skills of treating hepatitis C to simple doctors rather than keep it with ourselves. My talk won't be complete if I don't talk about how COVID has changed things. In the short run, all the countries that were trying to work on hepatitis C and do something in public health have faced a setback. A lot of healthcare staff has been redeployed for COVID-19 response. Hospitals are closed, endoscopy services are closed, staff is not reaching hospitals because of travel bans, quarantines. A lot of funds that governments were thinking of spending on hepatitis C treatment has gone for pandemic management. Drugs, test kits, they are manufactured in those countries, in many countries, and they are not being transported. We are spending more time looking after PPE rather than patients. And then patients also don't want to come to hospitals. They are afraid of COVID. Health has lower priority than food and survival. Migration has taken them away. and inequalities have grown. Lockdowns and travel bans have not made life easier too. However, we can look at it in another way if we look at what is the impact of this on hepatitis C elimination programs. COVID has placed a lot of emphasis on health sector. Health sector funding around the world would increase post-COVID. There is emphasis on infectious disease. People seem to understand disease epidemiology suddenly. Even lay public seems to understand a lot about infectious disease epidemiology. Hygiene and disease transmission. Also, the country governments are understanding that there needs to be universal health coverage, that even poor need to be covered for health, and that's going to change. We have discovered telehealth. We have discovered teleconsultations. Countries are spending more money in developing data systems. We have improved lab capacity. We thought that HCV RNA could not be done in the field. Today, we are doing so much of RT-PCR for COVID, even in small towns and small villages. We have learned ways by which specimens can be collected in the periphery and brought to larger labs. And that's going to change the way hepatitis C would be diagnosed and treatment would be given. The services have been decentralized. There is more emphasis on inequality, the vulnerable people. So I think we have a challenge here. We are accustomed to looking at disease only in terms of patients who come to us. But my request as the outgoing president of INASL to you is that we need to look at hepatitis C slightly differently. We need to look at it as a public health problem where we can change things drastically, much more than we have changed for any other disease since we entered practice. And that is to eliminate hepatitis C by diagnosing more people, treating more people. And then we need to use methods, techniques that we have learned in face of COVID. We have learned about teleconsultations, so we should be able to treat people even without their seeing us. We need to use point of care tests, so they can be done by a person in the field. Dried blood spots can be collected. They can come to a large hospital. Once diagnosis is made, prescriptions can be done on teleconsultation. We can transport specimens. We don't need to transport patients to hospitals. Also, in terms of tuberculosis treatment in COVID, we have realized that instead of supervised treatments, it is much better to issue patients drugs for a long duration so that they don't have to come to hospitals. That can be done for HCV, all 12 weeks of treatment given at one time. Drugs can be delivered to patient homes by couriers. Instead of having periodic visits, we can do that over teleconsultation. And we can possibly do monitoring for sustained virological response only once 12 weeks are over, and again through dried blood spots and using either antigen test or using simpler tests for PCR. So with that, again, let me thank the association for giving me the honor of being its president, and charge you and charge the association that we work with public health authorities to ensure that we take care of this one infection for which we can do really great things, but we haven't been able to. Thank you.
Thank you, Dr. Rakesh Agrawal. As a president, you have changed many things and new things have been added to INASL programs. And this thought-provoking, your presidential address has given us a chance to change our thoughts, and we should become a public teachers and not think as a hepatologist only. And new ideas have been given to us, and all of us should work in this direction, at least for elimination of hepatitis C from our country and worldwide also. Thank you very much. I wish to thank Dr. Jang Dilavri and Dr. M.P. Sharma Sahab, my teachers, who have been there with us for this presidential oration and the Dr. Madan Gopal oration. Thank you very much.
Thank you, sir.
Thank you, sir. So now we move on to the next session, that is debate on a very practical issue that we face frequently in our clinical practice. That is, should we be treating HBV infected patients in immunotolerant phase or not? So I invite the chairpersons for this sessions, Dr. Manoj Sharma, Professor, Department of Hepatology at ILBS, Dr. Setu Babu, Senior Consultant, Department of Gastroenterology and Hepatology, Krishna Institute of Medical Sciences, Hyderabad. Dr. Manisha Dwivedi, former professor and head, Department of Gastroenterology, Motilal Nehru Medical College, Allahabad. So over to the chairpersons.
Good evening, everybody. Welcome to this session. And this is an interesting debate on HBV infected patients in immune tolerant phase. Should they be treated? And we have two eminent speakers. First, who will be speaking for the motion is Dr. Madhumita Prem Kumar, Assistant Professor, Department of Hepatology, Chandigarh, followed by Dr. Manav Vadhavan against. So first I would invite Dr. Madhumita Prem Kumar for her part.
Thank
Dr.
you so much
Madhumita.
Thank you for the introduction, Manoj sir, and thanks to INASL, the scientific committee, for inviting me. Without further ado, I'll dive straight in because this is a difficult debate, and I have been given the uh, honor of actually speaking for the motion, but against practice. So I will be speaking about how it is necessary to treat people in the immune tolerant phase rather than what is conventional practice. So sir has done a wonderful oration and has told about the vital importance of actually changing our perception when we are dealing with viral hepatitis, if we even hope to get near eliminating the disease. So a large number of patients are infected with viral hepatitis B. And just to quickly go over what we are talking about is we are talking about the immune tolerant phase when the patients are E antigen negative, high HBs antigen, high HBV DNA, but the ALT is normal. So they are replicative, but they are not having so-called inflammation or normal ALT. Every guideline will agree that chronic hepatitis, whether it's E antigen positive or E antigen negative, where there's an elevated ALT, has to be treated. So for some reason, everybody agrees that high ALT should be treated. And the rest of the disease stages are essentially benign. So everybody thinks that we are going to go towards an active carrier or a functional cure state where there's loss of HBs antigen. But immune tolerant phase is not really tolerant and it is not really benign. There are many of them which are having a high replication and high risk of having disease complications as well. So there are some of them which are wolves in sheep's clothing. Again, going over the three major guidelines, for some reason, everybody decides on an arbitrary cutoff of ALT, either twice upper limit of normal or three times upper limit of normal. And in the ones where we have a gray zone in which the ALT is mildly elevated, then everybody recommends a biopsy, and everybody has a different age cutoff for initiating treatment beyond these standard indications. So people who have immune tolerance, they are tending to be requiring a biopsy, which makes many of them not follow up. They also have to earn their right to treatment. So they come with a lot of fear, with a very high HBV DNA, internet advice, and none of that fear is taken away when we say, oh, you're an immune tolerant phase and we just need to monitor you. That's the crux of the situation. We need to monitor them. It is not that we are going to let them go without treatment. And if it is not possible to monitor them closely, things could be disastrous. So let's go over quickly. There are many red flags with our current guidelines. The first is the reliance on the ALT, which is really not a good yardstick. Over-reliance of liver biopsy with all of its attendant problems, a reliance of fibroscan when there might be confounders, be it alcohol intake or NAFLD, and of course the age criteria. Anyone who is meeting the standard criteria of elevation in ALT, high age, family history of HCC, it is clear. But the problem is the gray ones which lie in between, and they are a large chunk of the burden of disease and the public health burden of disease. So why are we relying on ALT when we know in the immune tolerant phase, when it is going into immune clearance, there is no clear clinical parameter that marks. The ALT will be fluctuating. So if we are testing people at this point, we may end up giving them treatment. And the same patient, if we test at this point, again arbitrarily, we may let them go without any treatment. So in the milestones of heading towards cure, the DNA and the ALT, let's just take a look which is most useful. So what is the purpose of treating hepatitis B? The purpose of treating hepatitis B is actually to ensure that there is no HCC, there's no progression to cirrhosis, and we have the other surrogates, that is improvement in histology, prevention of HCC, and ALT normalization.
So that's the primary goal of treating hepatitis B. So my first piece of evidence, I'm taking you to Taiwan, the real HPV. So again, over here, the majority of patients were E antigen negative and more than 90% were ALT less than 45 without any complication. So what happened over time? The HPV DNA is actually that which predicts the incidence of HCC over a period of 13 years. And this is the largest community-based cohort over the world, be it E antigen positive or negative. So the risk of HCC is actually determined by the HBV DNA at entry. So patients who started off with a high HBV DNA, if they remained high, they had the maximum risk, 5.4, adjusted for all of these confounders, including presence of alcohol or cirrhosis or diabetes, they had the highest risk of HCC. People who had a spontaneous clearance, or a reduction in HBV DNA without pharmacological treatment, they had a lower risk of HCC, and those who started low and became high had a intermediate risk. So the HPV DNA appears to be that which actually predicts the onset of or incidence of HCC. The next flag that I picked up, the over reliance on biopsy. Now the biopsy does reveal inflammation far better than the ALT, but if you look at the study by Wu et al., the inflammatory score, the fibrosis score was pretty much the same whether their patient was E antigen negative, and this is because of the sampling bias. So over reliance of the guidelines on biopsy, although it remains the gold standard, is going to be difficult because it depends on where we are sampling the patient from. Now we are relying on fibroscan. Again, there's a problem. If the LSM is less than 6, we are happy. We won't treat them. I am happy not to treat them because apparently no fibrosis. If the LSM is more than 9, again, fine, we end up treating these individuals. But what happens, and the vast majority actually come in this gray area, the LSM is between 6 to 9. Liver biopsy, many of them run away. Even if we biopsy, we are not sure about the inflammatory level. So are we really missing something here? This systematic review actually suggested that those who were treated with nucleoside analogs had a far lower risk of HCC, whereas those who were untreated, this last large chunk. So are we missing treating our patients who are immune tolerant? A large amount of data suggests that nucleoside analogs, whether TDF or ETV, there is varying evidence of one being more successful than the other, but when it is adjusted, largely the evidence is the same. So they both work, and we are fairly sure that treatment with nucleoside analogs reduces cancer. In that case, why are we cherry picking the ones who will develop complications? So the risk of developing HCC in the immune tolerant people and in the immune active people, we found that the immune tolerant people are actually having a higher risk because they were ending up not getting treatment because of the current guidelines and because of that misnomer that they are tolerant. Lastly, what should be the age cutoff? Everybody is reducing the age cutoff. It started with 40 and now it has gone down to 30 years. And that's because the longer we live with the virus, the more likely it is going to have a replicative error or a mutation, integration into the genome, and risk of HCC. So there's this also interesting information. Mason et al. Recently reported in 2016 that the DNA integration is independent on whether the patient is actually in the immune tolerant or the immune active phase. And the risk of HCC is actually dependent on the level of replication as determined by the quantitative HBS antigen level. So the integration of DNA and the CCC DNA is equivalent whether the patient is in immune tolerant phase or in the immune active phase. And it is a question of the duration of stay. So this misnomer of being tolerant means that it is a high replication but low inflammatory state. But the risk of HCC and complications remain. My major argument against which is based on the point that we should start treating immune tolerant patients is it is cost effective because the complications of hepatitis C is far more when it comes to end stage, when it comes to cirrhosis, when it comes to development of HCC, transplantation and admissions. So if we look at it from a societal perspective in terms of the loss of productive years and in terms of treatment costs in end stage, it is far more cost effective. And a number of studies have now come in, including this latest one from the Korean group in gut in 2020, which actually has suggested that from the Korean perspective, with current treatment costs of generic drugs, it is cost effective to treat everybody in the immune tolerant phase. These other two studies have included patients who are both in immune tolerant and immune active phase. So just like with hepatitis C, I think it's time to realize that Hep B is also a disease that has an immense amount of cost in terms of complications of liver disease. And if the aim of treating hepatitis B is to prevent complications like HCC, decompensated cirrhosis, then definitely we are missing a large chunk of patients just because of the misnomer of it being a immune tolerant disease. So the crux is, are we prepared as a society to sit around with the current vaccine based status quo? If you're looking towards elimination of hepatitis B and C, is going to take till 2090 to eliminate the disease. Only if we start treating people are we going to be able to even have a similarity or a near society prevention by 2060. And the reason being is we are missing all these patients of hepatitis B, which are transmitting horizontally, including high risk groups. So high risk groups who are likely to transmit to each other, including PWID, people on dialysis, people in incarceration. These are the ones that are actually going to result in transmission of disease. And if we need to plug the leaky bucket, we need to treat these high risk groups. So increasing the expansion or eligibility criteria for treating hepatitis B, because the purpose is not served with our current things. So my final message is that all immune tolerant patients do not need treatment. I agree, but most deserve it, especially high risk groups and those with comorbidities, because they are at higher risk of decompensation, developing HCC. And with our current guidelines, we are going to wait till 2090 till there's some semblance of elimination. Are we really prepared to wait that long when enough evidence actually points that immune tolerant disease is not benign and a large number of them are at equivalent or as increased risk of developing complications due to the virus? So with that, I will close with these salient points. Thank you.
Manoj, can I make a quick comment?
Sure, sir. Sure, sir.
I think it's a beautiful talk, which is probably in favor, at least I think you would probably mention, or Manav would take up, those people who have got a family history of malignancy, and those people who have this kind of serology is very important. And what would Manav say? If only there is a drug like what we had success with tenofovir, a drug against CCC DNA, would our argument change? Manav, the floor is yours.
Thank you, sir. May I ask, do I actually even need to start the debate? Madhumita actually gave off everything. She said all immunotolerant doesn't need treatment. So should I even talk about it? She's given off the debate already.
No, I think, but still.
I'll go ahead with what I thought we should talk about.
I think you should fight with a lady. I mean, to put it to your point, fight with a lady.
Okay, now I'm not fighting. I'm just trying to convince you why all societies across the world have decided not to treat immune tolerance. Now, Madhumita has given us very compelling evidence that why immunotolerant people should be treated. Let me take you back a bit. So this was the definition which all the studies she has presented, except the Kim one. The Kim study from Korea did not take this definition, but this is a definition which used to be for immune tolerant CHB. S antigen present for more than 6 months, E antigen positive patients, DNA more than 10⁷, ALT less than 2 times upper limit of normal, and normal was taken as 40, and there was no routine talk about or assessment about fibrosis at that time. And this has changed. There are two major changes which have been made in the definition of immune tolerant phase. I'm talking about this because this is very important for deciding for or against treatment. It is very relevant to this debate. So normal ALT is no more 40. It is 30 for males and 19 for females. And we are not talking about 2 times upper limit normal. We are talking about immune tolerant phase as normal ALT. People who have 1 to 2 times upper limit normal are minimally active. They are a different class altogether. I'll talk about that subsequently. And assessment of fibrosis has come into vogue. So that special subgroup of patients which Madhumita has been talking about are mostly those who already have some inflammation, significant inflammation or fibrosis. And immune tolerance today does not include patients who have fibrosis to start with, at least F2 or above. So I thought, let me pose questions that why should we be treating, or what should we be looking at whether to decide for treatment in immune tolerant phase. I thought I came up with 4 questions. So first question is, what proportion of immune tolerant chronic hepatitis B have significant disease at presentation? This will make us think that we should treat all immunotolerant phase if they have significant fibrosis right at the time you diagnose them. The second question which came to my mind was, what proportion of immune tolerant CHB which you have already diagnosed, they progress to immune active HCCs or decompensated liver disease, or improve spontaneously. I'll try to give you evidence on that. Third question is when and in whom the transition from immune tolerant to immune active happens, what is the proportion and when it happens. And fourth question, which Madhumita has talked in detail, what is the risk of hepatocellular carcinoma in immune tolerant phase versus immune active. I'll talk about all these four. Give me 5-7 more minutes. So this is the first paper. This is a study from Boston, from Beth Israel, published in 2007. 59 patients with persistently normal ALT. Mind you, ALT was defined as 40 here, which was the definition on the basis of which most of the studies have been done. What they found out was 18% has more than or equal to grade 2 fibrosis, and 37% had significant inflammation on fibrosis. More than 1/3 of the patients had significant inflammation on fibrosis. But again, this value is 40. What they did was they did a subgroup analysis, dividing them into the current normal, which we accept, ALT between 0 to 25, and the high normal, which is 26 to 40, which now comes into your immune active or minimally active group. And look at the results. 95% of, more than 95% of patients who have normal ALT as defined by the current criteria had no fibrosis or F1 fibrosis. F2 fibrosis was seen in less than 5% of these patients. But the proportion changes when you're looking at a high normal ALT, which is 26 to 40, which is now considered a high ALT. So that is point number one. That answers our question number one. The proportion of immune tolerant chronic hepatitis B patients having significant disease is less than 5%. That makes first point against not treating all of them at the outset. Let's talk about this paper, which is Indian data. Manoj is one of our chairpersons. I'll ask him to comment subsequently. But this is a paper which Manoj published. Manoj was the first author in this. They took 73 persistently normal ALT patients. And what they showed us was 40% of these patients had more than stage 2 fibrosis. Now, I want to shift your focus here. He did not talk about immune tolerant chronic hepatitis B. He talked about persistently normal ALT. And here the persistently normal ALT was less than 40 again, which I've already told you, highlighted that. This is one line which they have written in the paper, which I found out. As per the updated ALT values, only 27 out of 73 had a persistently normal ALT. And look at the HBV DNA values here. They were as low as 2 log up to 9 log. So this group was a heterogeneous group which did not have all immune tolerant chronic hepatitis B. They had a significant number of patients which will fall into immune active group, hence the higher incidence of fibrosis. Hence, let me reiterate fibrosis assessment, if not a biopsy. We don't do biopsies routinely. We have problem, and Madhumita has pointed that out. Routine assessment of fibrosis with elastography should be done before you classify your patient as immune tolerant or immune active. That is mandatory. Let's come to second and third question. I'll take them separately because they talk about similar things. So what proportion of immune tolerant CHB, immune tolerant which you have diagnosed as ALT less than 30 or less than 20 in females, whether they progress or improve, if they do, in what proportions, and when does the transition happen from immune tolerant to either inactive disease or active disease? Let's look at this paper. This is a Chinese paper published again in 2007. These were all true immune tolerant chronic hepatitis B patients. All of them underwent a liver biopsy before recruitment. 57 patients. Mean DNA was more than 9 logs. All of them had normal ALT less than 40 in this study. What they found out was they followed all these patients for 5 years and did a follow-up biopsy after 5 years. Over 5 years, 9 of these 57 patients developed ALT elevation and they were considered censored. That means they were taken out of the study. That means they have moved from immune tolerant phase to loss of tolerance. Whether they have gone into active phase or inactive phase, we'll talk subsequently. Look at the median initial fibrosis stage. Median fibrosis stage is 1 in all these patients, ranges from 0 to 1. 9 were discontinued. That leaves us with 48 patients. When they looked at fibrosis progression, 5 of the 9 patients who developed raised ALT developed fibrosis progression, and only 3 out of 48 patients who were actually immune tolerant over those 5 years developed fibrosis. This tells us the proportion of patients in immune tolerant group who developed significant fibrosis over a period of at least 5 years. The proportion is small. Let's look at how many of them improve. Those who are losing tolerance, that means either they're going to an immune active phase or a quiescent phase. How does it happen and what is the proportion approximately? This is a French study, 2007 again. I don't know why all these studies have come up in 2007, but they're very interesting. So all immune tolerant chronic hepatitis B patients, DNA was more than 10 raised to power 7 in all. ALT was less than 35 here. Mean age was 29. 20 of these 40 patients which they took had no fibrosis and 20 had F1 fibrosis. And the median follow-up was 3 years, varying up to 102 months, which comes to around 8 years. They had a long-term follow-up on 31 patients. 12 of these 31 patients had loss of tolerance. Look at, so this is 38%, but look at what happened. 6 of these 12 developed inactive disease. They did not have progression in fibrosis. DNA spontaneously came to low limits. 3 of them developed chronic hepatitis B, and 3 of them developed raised ALT and then returned to tolerance. So in effect, 19 plus 3, that means 22 of the patients out of 31 continued to be immune tolerant. 6 patients developed inactive disease and only 3 patients needed antiviral therapy. This is over a period up to 8 years after diagnosis. So that is how the real immune tolerant, which we are talking about, go on to have progressive disease or fibrosis or cirrhosis or HCC. Last question. Now, everyone is talking about this, especially after the Kim Korean study, which came in 2018, which Madhumita has quoted. What is the risk of hepatocellular carcinoma in immune tolerant versus immune active phase? Let me draw your attention to the methodology of this study. So they took 413 immune tolerant patients. Definitions were absolutely fine because they took ALT as 30 as per the new definition. Compared them with 1,497 immune active patients. Mean DNA was 8 log, varying from 7 to 8.4. Again, it makes them immune tolerant. Median age was 38. Now, here's the problem. So they followed up these patients for 1 year. And at the end of 1 year, all those patients who continued to be immune tolerant were taken as immune tolerant and blanketly decided not to be treated. Those who raised their ALT in that 1 year were classified as immune active category and decided to treat. So that is where the flaw is. So when these patients are being followed up for 8.6 years, they are not seeing whether they are transitioning from immune tolerant to immune active phase. I'll show you how did I come to that conclusion. Now this Madhumita has shown you that the risk of untreated immune tolerant developing HCC was higher as compared to treated immune active. Now why does that happen? Let's look at what they talk about in smaller detail in fine print. When the diagnosis of HCC was made in these immune tolerant patients were significantly older. Let's discount that. I'm not concerned about that. What they found out was the levels of DNA in the patients of immune tolerant group who were diagnosed HCC as compared to baseline was significantly lower. Albumin levels were significantly lower and platelet counts were significantly lower. Now this tells us somewhere between year 1 when they were recruited as immune tolerant to the time when they developed HCC, they had moved on from immune tolerant to immune active phase, which was not picked up and not treated. So that is the point I'm trying to make. Immune tolerant patient does not need treatment for long periods of time, for 5 years, for 10 years. But when he transitions to immune active, that is the point you want to treat. Therapy which we are talking about is not finite therapy. It is lifelong therapy in almost all patients. The more you can delay the therapy, the better it is. It does not make any financial sense. It does not make any epidemiological sense in treating all immune tolerant patients when you can avoid treatment very safely for a period up to 10 to 15 years. So that's my point which I wanted to make. So the risk of HCC is overrated. There is not even a single study which demonstrates that antiviral therapy is beneficial in reducing hepatocellular carcinoma or cirrhosis or liver-related death. All studies which talk about this actually have included immune active phase patients and not real immune tolerant phase patients. So I'll rest my case here, sir. To summarize, true immune tolerant patients are defined as E antigen positive, DNA more than 10 raised to power 7, ALT as per the new definitions of normal less than 30 or 19, whether you're talking about male or female, and no fibrosis or F1 fibrosis. Fibrosis progression happens in a small proportion of true immune tolerant CHB over a period of 10 years. Regular follow-up would identify those who transition from immune tolerant to immune active phase. A large proportion of immune tolerant chronic hepatitis B may improve spontaneously. I've already shown you that, and they may not require any antiviral therapy at all. So why do you want to expose everyone? Many of these are going to improve. Most of these are not going to require therapy for next 10 years. So antiviral therapy is not required in true immune tolerant phase. All you need to do is watch them, pick them up when they transition from immune tolerant to immune active, and you'll be surprised to see many of them will actually transition from immune tolerant to inactive phase, which will never require treatment. Thank you for your patience.
Madhumita, would you like to make a quick comment? Before that, I would again request Manav to make the comment on would the stand will be the same in a patient who's got a family history of HBV HCC? Would the stand be the same?
So,
Madhumita, you answer first.
I will answer first. If there is a family history of first degree relative of HCC, yes, immediately treat. I wouldn't wait. Not only that, let me take the point one step further. Even if there's a family history of HCC, which is not a first degree relative, I will still treat. We never know what environmental factors are influencing HCC in such a patient. Second point, sir spent a lot of time explaining exactly what I'm saying. ALT is probably the first and the cheapest and the worst parameter to judge whether inflammation is going on. It is cheap, widely available, reproducible, yes, but it does not really point out whether the patient requires treatment or not, because there's a wide level of fluctuation and we never know when we are testing the patient. Secondly, you mentioned the French study where the time point of entry of the patient was about 29 years and they were followed up for 4 to 5 years. We are not going to expect any complications. And you very well mentioned that the time of transition from immune tolerant to immune active was not picked up in many cases. And the first time they presented was not with cirrhosis or immune active hepatitis B. They came for the first time with HCC. So are we really going to wait for our patients to present for the first time with HCC, or are we going to take a careful look at them every time? And do you think that immune tolerant patients are going to come every 6 months, faithfully get their ultrasounds and their AFPs done? And whether those LFTs that they do every 3 months, do you think it is viable in a country like India that people are going to spend that much money? What about patients who have got high risk of transmission to others, like PWIDs? What about people in military? What about people who are on dialysis? Does it make economic and financial sense to actually reduce or cause viral suppression in such individuals so that they don't add on to the public health burden of disease? None of those points are addressed, and it's time we stop having this blinker tunnel vision as clinicians to manage hepatitis B. We have to look at it with a societal perspective and to actually see, break the chain of transmission so that we don't end up with more of these individuals till 2090. I mean, our entire lifetimes will go by and we'll be debating the same thing and cherry picking about ALTs and LSM values, when the fact is the clock is ticking and we have to eliminate hepatitis B. Just vaccination is not going to help. We have to expand the eligibility criteria. I completely agree with you, sir. Every immune tolerant patient, true immune tolerant, does not require to be treated. But how do you know which person is immune tolerant and which is immune active? We have no good, reliable test of proving or disproving otherwise.
Dr. Manoj,
make a point.
Can we ask Manoj to make a comment? Then, Madam.
Manoj, comment, please.
Manoj, you
actually defining immune tolerant is a bit tricky, because even if LFT is normal and liver biopsy is showing minimal inflammation, if you do immune responses, then there are T cell response against HPV is still going on. So whether what we currently define immune tolerant is really immune tolerant, that is a very problematic situation. That's the whole point.
Manisha, you wanted to say something.
Yes, I wanted to point out that there's no way how you can predict how long the immune tolerant phase would last. And with the normal ALT and AST, if you give them antiviral drugs, the response at best would be nearly 19 to 20%. And the rest of them would develop resistance over time and would be difficult to manage later on.
I want to ask Manav and Madhumita. Manav,
Sir, before I say anything, you have to let Professor Rakesh Agarwal speak.
Yes.
I completely disagree with Madhumita about eradicating hepatitis B by treating everyone. Dr. Rakesh Agarwal, I want to comment on that, sir, please.
Oh, I think both of you spoke very well, but I would have only two questions for Madhumita. Madhumita, firstly, the viral load in these patients is very high. And of the total population that we have, a large proportion is in immune tolerant phase. The higher the viral load, the greater the chance of resistance developing. And all the drugs that we have available today all act by the same mechanism. So combining two doesn't help. And that's, I think, the biggest concern why we are not treating, something that we hepatologists don't think about. And the second issue is, you said, will people come every 6 months for getting an ultrasound done? Does anybody say that patients with any other stage, immune active, who are on treatment should not get that done every 6 months? I have my own views on that, whether that really every 6 months really helps in our setting. But, there is nothing that says that if you are treating them, then that's going to become unimportant. Over.
Manoj?
Yes.
Before we wind up, Manoj, would you like to say, Madhumita, I think both the points are very, very important.
I will answer.
Yeah.
I have the incongruous job of actually pushing against what is conventional practice, and I will respond to Professor Agarwal's 2 points. The first is the viral load. I agree that high viral loads are going to be an issue, because everybody with immune tolerant phase who comes with a high viral load is to determine whether they are true immune tolerant or they are actually not. Well, first, you have a problem with this word immune tolerant. It just means that our immune system is not launching an attack against the virus. The virus exists, it is replicating, it is integrating with the human genome. It will cause at some point mutations and HCC. So everybody with a high viral load, maybe we observe over a few years and see how they're behaving. I would say that even if one ALT report is abnormal, this is a person who is having some ongoing inflammation or necroinflammation and should be treated. So a very close follow-up over 2 years will actually determine which of these immune tolerant people, and we can say cut off of 1 year, 2 years, 3 years, whatever. But we have to debate this. We determine the subsection which is actually having an inflammatory problem, which we miss with our usual follow-up. Thereafter, we can decide whether they are true immune tolerant by biopsy or otherwise. So a better follow-up and a close watchfulness before determining who is to be on therapy. So I hope that answers the viral load question. The second thing about resistance. Sir, COVID-19 has shown we can produce a vaccine in 1 year. We have to generate the demand for it. We have to generate the society's feel, and 257 million people worldwide with hepatitis B. If we don't as a society raise the problem and drive research into determining a cocktail cure, then we'll still end up be debating this 10 years later that we cherry pick and wait for people to actually develop complications and then treat. So idea is that we push for research, and I'm sure drugs will be coming in the pipeline. There are phase 2 drugs available. So resistance should not prevent treatment. Just like with HIV, availability of drugs and chronic treatment with tenofovir has shown the adverse effects are less. Even if we were not treating them, we are not treating them anyway. We're not treating these immune tolerant patients anyway. So even if they develop drug resistance, the likelihood of a cure developing later is very high. So I am not saying treat every immune tolerant person. I am saying find out the ones which actually deserve treatment and treat them, and especially high risk groups, so that we can reduce the burden of disease.
Manu, final comment from you? Final comment? Do you have any final comment, Manu?
Sir, the debate was whether all immune tolerant should be treated or not treated, and we are saying the same thing. Both of us are talking about the same thing, but from an epidemiological and a societal perspective, it's a disease which has a vaccine. Rather than talking about treating everybody, we should talk about vaccinating everybody. If one message has to go from this debate, it should be that universal vaccination will eradicate hepatitis B, not universal treatment. Thank you.
I think both of you have done a very good job. I think you showed a lot of sheep. I still feel I'm a sheep before the Hep B, because so many questions remain. We were actually looking for an anti-CCC DNA drug, which could be much more better and all. I think the time is up. Dr. Rakesh, you think we should close, or should we ask? Time has come up to close.
Yes, sir. We are already late, sir.
Yes.
15 minutes. Thank you. Thank you very much. Thank you all.
Thank you, sir. Thank you for chairing a wonderful debate. So with this, we come to the end of today's session, and we have had wonderful debate, and we were able to finish in time. So I thank everyone for participating. I thank the chairpersons and also all the speakers. And over to Dr. Kaushal.
Thank you all. You would all agree that it was a wonderful session, the entire 3 hours of it. And tomorrow, and day after tomorrow, I promise you, we have more interesting sessions coming up. So tomorrow we'll start at 5:30 with Dr. Dhiman talking about his 10 years journey as editor-in-chief of Journal of Clinical and Experimental Hepatology. At 6, we'll start our main sessions with the podium presentation award session for young investigators, followed by an oration by Dr. Kudo, and very interesting case-based clinics in hepatology presentation and discussion by panelists. Along with that, in Hall B, there'll be a parallel session on pediatric hepatology, very interesting talks, and how the pediatric patients, when they go on to develop adolescents and adults, carry with them the liver disease they are harboring, and how they come to us for diagnosing and managing these patients. So it's very important for us as adult hepatologists also to be aware of these illnesses. So let's meet tomorrow again, same time around 6 p.m. Thank you very much for being involved in this presentation and discussion. Thank you. Good night.
Good night.